Voice clear. Okay, thank you. Today, actually, I've been asked to do this presentation. However, I am not a trauma surgeon or a trauma, an emergency. You know, in emergency program, there is also like a trauma, which is like a new specialty, but you have to have like surgical also skills or surgical certificate or residency in surgery. And this is one of the important specialty. We consider like our hospital in Saudi Arabia, we have a limited number. If we don't, I can tell you, like, we don't have a trauma level 1 center in Saudi Arabia. Some people, they will say National Guard in Riyadh consider trauma level 1. It's not true, to be honest with you. We can say like it's trauma 2 and center. Because it has a specification and it has criteria to fulfill this, to be recognized as a trauma level 1. You know, just to, I have nothing to declare. And the establishment of a trauma center has become increasingly important. In USA, there is a lot of trauma centers in major cities where it's like a referral center for those victims in accident or who has a serious injuries. And for the treatment of critically injured patient and enhancing hospital services. And the trauma center should be within the emergency department. It is not like a separate department. And this detailed guide will explore the essential of importance of trauma centers, including their definition, we'll talk about it, and categorization, level 1, 2, 3, 4, 5, and the steps required to set up one trauma center, and ensuring that they serve as a very vital resources in saving lives and reducing the impact of serious injuries. As you know, here in Saudi Arabia, we have some hospital that they are considered like a trauma center, but not level 1. Okay, for example, like Shemaisi, King Saud Medical City, and National Guard, King Abdulaziz Medical City. King Fahad Medical City, it's considered, it's not like an accepting a lot of traumas. King Faisal also is not accepting traumas. Most of the time, they refer it to other hospitals. That's why trauma center, it's very important, and it is like a specialized medical facility which provide like immediate care for patients suffering from like severe injuries and life-threatening conditions. Of course, these centers are should be like equipped, okay, to handle this wide range of medical emergencies, traumas, and car accident, sometimes falls, gunshot wounds, and other traumatic injuries. I remember when we were doing our scholarship in emergency, we had to do like trauma rotation, and we should go to a trauma center. In Canada, there is a like in Toronto, Sunnybrook Hospital, which considered like a trauma center, and it's all the whole day we are seeing like gunshot, falls, a car accident, and a lot of other like traumatic accident. And usually, this is like kind of cases, as it's mentioned here, penetrating trauma, which you know, like object piercing the body, leading to open wound, significant or blunt force trauma occurs during a car accident or striking the body by any hard object, causing injury, broken bones, or concussions, Common causes include falls, vehicle crashes, burns, assault, and other surgical procedure. So how we can define the trauma center? It is a specialized care center which should be staffed by a highly trained medical professionals, and it play an important role in saving lives and minimizing long-term disability for involved patients. Their role is to coordinate and effective approach to trauma victims, and also to ensure that the patient will receive the appropriate treatment as soon as possible, and improving the chance of survival and the outcome. And it is like 24 hours daily, and it is like located within the hospital, and as I mentioned, it offers services that complement and not replace the emergency department. If you remember, like we had like a gas explosion that was in close to National Guard. That was like about maybe 15 years ago or more than that. And you can hear this, the sound of the explosion. We heard it all over Riyadh. And there was so many victims. And at that time, the main hospital who had these cases were King Abdulaziz Medical City, which is a National Guard. But still, at that time, it was a trauma center, but it was not felt like, you have to have a specialized staff, like trained and working in the emergency. Most of our staff now, they are emergency certified. They are not a surgeon. That's why in level 1 trauma, it should be a surgeon available 24 hours, which we don't have actually. And hopefully we will have it soon. So level 1 trauma center, like the one in Sunnybrook or one in Texas, one in Kansas City, which considered one of the major trauma center in the world. It's like 5-story buildings, and it has trauma. It has specialized. Even the nurses, they are specialized in trauma. Even the physician, they are certified in trauma. So it's level 1 trauma center. It's a comprehensive care and regional resources for all injury aspects, with a focus in research, community education, fellowship program, and a lot of to improve the trauma management provided to these patients. Level 2, where they initiate the definitive care for all patients. I can label, for example, King Abdulaziz Medical City, National Guard, or King Saud Medical City as a level 2 trauma center, which they start the definitive care management, but they refer the patient to in the hospital, within the hospital, for further management. Where in level 1, they have ICU in the trauma center, they have emergency, they have a surgery, they have everything in the same trauma center, which we don't have it. Level 3, which provide the emergency care, intensive care, and stabilization with active outreach and education program, and they refer the patient eventually to a trauma center. This is, let's say, like, for example, in for example, like other places out of Riyadh, where they can stabilize the patient, they can provide critical care, and they will arrange for transfer to level 1. Level 4 just offer diagnosis and stabilization, and just send the patient. They are following the ATLS guidelines. Level 5, which prepare patient for transfer immediately, like which say, for example, patient, for example, like he had an accident in Al-Guaiya or Mzahmiya or someone out of Riyadh, okay? And they didn't have any surgery, they didn't have, so they are doing the initial assessment and they will try to arrange for transfer as early as possible. Okay. What is the, sorry. I didn't have the part of the, okay. What we should have to set up to set, what is the steps, okay, we should consider to have like a trauma center. Okay, first we have to understand what is the requirement, okay, which is established by, for example, by the governor or the government, and also by the involved Ministry of Health, okay, and consider also the budget for this center. Usually it is because it will involve like specialized physicians, specialized nurses, and also to set up the uh, the trauma system and prepare for the land and for the area that need this place, and it should be integrated with the emergency department. The hospital should be prepared also for this changes, for example, and should be equipped with, for example, like X-rays, CT scan, MRIs, and other specialties like orthopedic surgery, pediatric surgery, general surgery. Okay. And also in these centers, usually there is a continuous education and sometimes like fellowship program and training, and for to update with the new guidelines in the trauma center. So this is the most important. So there is a lot of components for trauma center setup. As we mentioned, after having these steps, there should be specialized, as I mentioned, specialized staff, which is like, you know, highly skilled personalized team, including trauma surgeons, emergency physician, anesthesia, nurses, and other medical and you know, critical care, provide immediate also nursing wise, and all these subspecialties should be, and also the equipment, very important. This is what we okay. Like advanced medical equipment, CT, as I mentioned, X-rays, like surgical tools essential for trauma, equipment enables for rapid diagnosis and treatment, and which leading to improve the outcome of this patient. Okay, as I mentioned. So also part of the setup for trauma center, you have like to have like a mobile field hospital for capacity issue, because sometimes, and this is what we had in this accident that was happened like 15 years ago. And if we remember, like during the Gulf War, okay, invasion of Kuwait, and after this the Gulf War, I remember we were like volunteer, okay, and we went there as a volunteer. We didn't finish medical school yet, and we went there as a volunteer, and we saw this mobile hospital, okay, and which is help during mass casualties, if there is a lot of number of patients or victims coming, and actually we received a lot of victims, because during our time there, there was an invasion of Al-Khafji, if some of you remember, and then the airstrike by the allies and attack this soldiers, and we received a lot of cases in this mobile hospital, because we were in the desert, so there is no time to build a trauma center. So we've been using this mobile field hospital, okay, which provide, like additional spaces for trauma. And when we don't have this like facility there, or buildings like in the modern cities, okay, and it is very durable and very portable and easy to mobilize it, and it's very important, and it did a great job actually. Okay. Sorry, this is this one. About the level 1 trauma center requirements, okay. As I mentioned before, you have to have enough numbers so you can establish level 1 trauma. For example, like in areas where you don't have like expecting a lot of victims, this will be considered like an objection for a level 1 trauma center. The location should be in a place where that you are expecting, like in a highway, like an area congestion with a lot of people, and there is a reported cases, like there is annual volume of patient data that necessitate the importance of establishing a trauma level 1, and the quality assessment program, okay, and around the clock surgeon, 24 hours 7 days, okay, and for toxicology, substance abuse, and continuous education of the trauma team, and specialty care availability like orthopedic, anesthesia, pediatric surgeon, general surgeon, and continuous research and training, and also in the media for continuous education and leadership, and referrals for communities. When we go to level 2, which I think we have it like King Saud Medical City and King Abdulaziz Medical City, I think we have like quality program, and we have educational programs and specialty care, and we have a trauma surgeon in these places, and it is very important and essential to have like to be recognized as a level 2. Level 3, as I mentioned, it is outreach, like it is in the peripheries area where they can engage in the management, initial management, and then they will arrange for a transfer to level 1 or to a highly specialized center. Okay. For example, like if you are in Al-Muzahmiya or Al-Guaiya, you have a patient involved in a significant car accident or victims. So you will do the initial assessment, and then you can, and there is a program in the Ministry of Health that they refer to the closest hospital where they have the facilities. Okay. In level 4, okay, the only thing they are applying like the ATLS guidelines, and they are trying to stabilize the patient and following the ATLS protocol, and send the patient to the nearest level 2 or level 1 hospital. Okay. Level 5, which is the lowest, which I think this is like most of the places in the peripheries, okay, they are arranging for transfer as early as possible, and they just like a paramedics and initiate the care services and activate the protocol by sending the patient immediately to the nearest hospital. For trauma, setting up trauma center, we have to have a budget, which is very important, which and see the outcome of the cases, and there will be annual assessment and understanding the potential for immediate and long-term financial support, and ensuring accurate documentation for proper reimbursement for trauma services. And correct coding also is essential, especially now with the involvement of the insurance, okay, and the reimbursement for the trauma care. Building a trauma system. So it needs some system-wide buy-in. Success hinges on the involvement and understanding of the entire hospital ecosystem, phases of care, integration across all the phases, from the emergency to the surgery to anesthesia to ICU. This is all in the trauma center, okay? And it should be also started from the pre-hospital to follow up. Quality and compliance, embedding quality and regularity compliance from the start is very essential and very important. What is the capacity planning for trauma center? For example, we have like anticipating and planning for unpredictable patient volume is a key challenge, and this is very important. Okay, for example, like if you have, so that's why we are sometimes doing like this drill cases. For example, like we are doing it like maybe once or twice every 3 months, and expecting significant trauma or explosion, or you have to expect there is a very huge volumes, and you have to be trained, you and your staff and your emergency physician and surgeon for such. That's why we are doing this codes and drills every now and then. Okay. And develop a staffing model that can adjust to surge in demand if it is necessary, okay? And to ensure the resources such as beds, operating rooms, and this is sometimes we are doing it during Hajj season with our colleagues in the emergency and the Ministry of Health with the Ministry of Pilgrims. They are doing a great job during Hajj season, where they are doing some exercises, okay, and see how much they need beds, operating rooms can be expanded without monopolizing hospital services. Yes. For the community outreach education, we highlight the positive effect of the trauma center on the local community, and also implementing programs to educate the public on how to prevent also traumatic injuries. This is part of the trauma services that provided to public, okay, through the media, and also raising the awareness about the trauma center role and capabilities within the communities. This is a very important part of the education of the community. Okay. What is the importance of the mobile field hospital for disaster responses? As we mentioned, okay, it is very important because and it's very useful for the quick deployment. Mobile field hospital can be set up quickly and immediately, and to respond to the emergencies and disaster. And this is what we are doing during Hajj season, or during during crisis. Okay, and this hospital can be adapted to various situations, providing very essential care with when it's needed. okay? And and we have to now this is one of the fellowship program even in the emergency disaster preparedness, okay, where we have to prepare with mobile field hospital, which is very crucial for the effective disaster response. So it is a long-term durability to construct it, yes, to provide reliable services over extended period. And also it can, the equipment equipped to maintain a controlled environment regardless of the external condition, and the ability to tailor the setup to meet medical to meet the medical and logistical needs. So addressing trauma center challenges. What kind of challenges we usually face with this? First, financial. Okay, so we have to navigate the economic aspect of running a trauma center while maximizing its values. Okay, that's why we have to see where is the location, what is the needs, what is the important of establishing. Okay, because sometimes there is a financial issues. Also, managing the need for operation of trauma centers. Okay, and from patient care to staff coordination, which is also like the specialties, pediatric surgeon, general surgeon, trauma surgeon. Okay, and ensure adherence to state and federal regulation or the, okay, for trauma care delivery. So how you optimize the trauma care center performance? By quality, so continuous monitoring and improvement of care quality, and tracking the patient outcome to ensure the highest standards of trauma care, and also to implement strategies for ongoing improvement and performance enhancement. I think this is the end of the lecture. I know it is boring, okay, but this is what I can get for you. I'm sorry if some of you slept, and if there is any questions, I'm more than happy to answer. Okay. Some of you were asking, I don't know, but I think our coordinator, Omnia, please, some of the attendees, they were asking about the lecture to be in the YouTube. So you have to write for them what time it will be in YouTube, and because it's supposed to be once we finish, I think by today it will be all in the YouTube, and the link will be sent to you. السلام عليكم. السلام عليكم ورحمة الله. Uh, our lecture now, it's about abdominal trauma in pediatrics. And as you know, this is a very important topics. And yesterday we've been talking about trauma, and we mentioned about some trauma in the abdomen, why the patient is still not responding, not improving. And so we have to consider bleeding or other parameter that we should consider in these cases. So today, abdominal trauma, it is a significant medical concern and sometimes lead to complication, and we may lose the child or the pediatric victims or an adult even if the treatment were delayed and you didn't discover there is a bleeding or what is the real abnormality or what's going on. But with the advancement of the CTs and ultrasound and X-rays, it made this evaluation very quick and less invasive. Yet, clinical diagnosis remain very vital and very important. That's why in these cases, we consider having you should have a high index of suspicion if you are dealing with a patient who is continuously hypotensive and he's not improving and he's not responding. Okay, this presentation will review common injuries and what is the diagnostic standard and management practices, what we should do. It will be brief, okay? Because I don't want to, we are not surgeon. I'm not a pediatric surgeon, okay? But I will tell you from the emergency point of view what we should do, okay? These cases, how you approach them and what you should do before you before you refer these cases to the concern or to the right specialties. As you know, pediatric abdominal trauma, it's a leading cause of death, okay? And abdominal trauma, one of the causes of high mortality and morbidity in children, especially with blunt trauma, okay? Which is more common than penetrating trauma. Usually the mechanism, most of the time, motor vehicle accident and child abuse. Now it's become a common cause. And the injury mechanism varying by age. Okay, the younger the age group, they are prone to more injuries compared to other older age group. And we'll talk about this. Non-operative shift. This is the interesting thing in pediatric, where we notice that recently there is a significant shift towards non-operative. We don't do operation in most of the abdominal injuries unless there is a strong indications, okay? But still surgical consultation is it is very critical and it should be done early to avoid high mortality. Okay. So as we mentioned, the causes usually, okay, motor vehicle crashes. It is one of the leading cause of blunt trauma in children, which is more common than penetrating trauma. Child abuse becoming now a significant cause, as well as bicycle accident, okay, are at risk of sustaining blunt abdominal injury, sport injury also, okay, and recreational activities can also lead to blunt trauma in children. Pathophysiology of abdominal trauma. As you know, we have like children, they have unique anatomy, okay, where there is a small abdomen where all the organs are situated closer to each other. So if there is any injury in the abdomen, it may damage the liver or spleen, sometimes both, okay, which increase the risk of multiple organ injuries. Also, the physiological differences, okay. Children, they have less reserve, physiological reserve and more pliant skeletal compared to adult. Okay, like for the abdomen or for the chest, if there is any damage to the chest, because the very unlikely to have rib fracture. Okay, but they are more prone to lung contusion. Okay, but we are talking about the abdomen, and the abdomen also for the adult, there is the strong muscles, abdominal muscles, and all these things that can protect the internal organs, while in the children it is still the wall, the abdominal wall, and this subcutaneous structure is still, it's not well developed, and it cannot protect the internal organs. Energy transmission, the lack of protective tissue in children also, as I mentioned, means that the force of blow transmit quickly and more forceful energy to the internal organs. Very important when you are dealing with these cases, you have to know how the mechanism and what is kind of investigation and how you approach these cases. This is just a general, okay, about abdominal trauma. Okay, certain mechanism like handlebar, okay, or seat belt injury should raise a suspicion of intra-abdominal. If you find like bruises in the abdomen or in the epigastric area from the handle, so you should consider there is abdominal injury. Okay, and fast, it's now becoming very useful in diagnosing if there is a bleeding, but it cannot, okay, rule out any abdominal injury. You have to be careful. If there is a negative fast exam, it doesn't exclude like a splenic laceration or liver laceration or intestinal laceration, whatever, okay, injury. So you have to do repeated assessment and consider advanced imaging like CT or with even contrast. Non-operative management, most of the children, and this is like good for the abdominal injuries in the children, and this is why they are unique in this injury, this kind of blunt injury. Most of them treated conservatively with no surgical involvement. Okay. DPL, as I mentioned yesterday, it has very limited rule in abdominal injury or in a trauma in children, except, for example, like if you are thinking or expecting, they said very limited, it has a very limited role in bowel perforation. If there is a suspected bowel perforation, DBL sometimes may be useful. Splenic injury, this is considered the most common. Okay, more than up to more than 30%, according that this is considered having a splenic fracture or splenic injury. Okay, and also, but the interesting thing, and we will come and talk about details of everyone in the next few slides. Okay, they don't need also operation, surgical intervention. Okay, so initial resuscitation. Okay, the most important, normalize the signs. Okay, patient very tachycardic, hypotensive, so this is your primary goal through ABC ATLS guidelines. Okay, then number 2, maintain perfusion, okay, of these vital organs, the abdominal organs. So what is the guidelines principles in pediatric trauma? ATLS, okay, adherence. So initial management should follow the advanced trauma life support guidelines, and child-specific care. Also, there is a management must be tailored to the unique need of pediatric patient. Okay, the younger the age group, the more prone to have more internal damage, okay, internal injuries, internal organ injuries. So you have to consider it. What is the initial management of pediatric trauma? Primary survey. So immediate identification of life-threatening injury following ATLS, as I mentioned. So airway, breathing, circulation, airway with breathing, ensuring an open airway is a priority with intubation necessary for those unable to maintain their own airway. Circulation, evaluating the circulation to detect life-threatening bleeding, okay, with attention to vital signs and physical appearance. So that's why exposure is very important, as I mentioned yesterday. Neurological examination, completing the primary survey with a quick neurological Glasgow Coma Scale, pupils, and disrobing the patient, yani expose the whole patient for a thorough check. What kind of imaging study we are doing usually? Sometimes we do chest X-ray and fast exam. Chest X-ray is valuable for identifying conditions like rib fracture and pneumothorax, because sometimes rib fracture can damage the liver or the spleen, okay, the lower ribs, okay, and for determining the need for further imaging. Fast is very important, and it's very quick evaluation method, and it's been now one of the main and most important item that should be available in the emergency department, every emergency department, okay, which help to make a decision for a CT scan or operative room necessity, as we mentioned yesterday, okay. If you put your probe and you notice that there is a bleeding or something and the patient is not stable, he should go to operating room. If he's stable, blood pressure normal, everything normal, but he has some element of bleeding there, then this patient can go to for CT to give exact where is the area and how bad is the bleeding. So what is the fast useful in a CT decision aid, okay, in deciding whether a CT scan is necessary, and non-definitive, it does not definitely exclude intra-abdominal injury, as I mentioned before, and may need to be repeated. Secondary survey, after doing the primary survey, like taking a proper medical history and complete medical is taken, including medication, surgical history, last meal, and allergies history. Further image, additional radiographic imaging and lab work may be included in this secondary survey. Laboratory studies, very important, okay, for a patient, evaluating patient with abdominal injury, blunt abdominal injury, like, liver enzymes and CBC, hemoglobin level, and all these markers that can help to determine the need of transfusion or to tell you if there is any significant amylase, pancreatic injuries, or whatever. Okay. CT scan in pediatric trauma. CT scan is the preferred imaging study. We are using it a lot in the emergency department, especially for trauma, abdominal injury, traumatic abdominal injury, and also other injuries like head injuries and okay, and and it's been very useful. And but you have to be careful with the radiation concern. As you know, the radiation from the CT is very high compared to other imaging study like ultrasound or MRI. Also, as we mentioned yesterday, that CT should not be done, or you shouldn't send the patient for CT to if he is hemodynamically unstable. Okay, he should immediately taken to operative care. Immediately to the operative care, yes. diagnostic peritoneal lavage, as we mentioned here in the peritoneal lavage, this is, as I mentioned, it is now, honestly, it's rarely indicated, okay, in the evaluation of abdominal trauma, but have been largely replaced by by FAST. And usually now, we prefer that if it is to be done, it will be done by surgeon, and we are talking like an emergency physician, okay. And as we mentioned, and because of the most solid organ injury do not require surgical intervention, positive DBL has limited clinical significance in the management of solid organ injuries. Even if it is positive, it won't help, okay. Because it won't require surgery. Bowel injury detection is the only thing, to be honest with you, it has some high sensitivity, okay, in the detection of the bowel injury, the presence of bile, food particles, and can be used as a diagnosis of small bowel perforation. So what we should do when we deal with this abdominal trauma, okay, we'll follow the guidelines, okay, initial, yes, ATLS, and most of the time they are coming to the emergency just complaining of abdominal pain and this. So what you should do, initial resuscitation, the goal is to normalize the vital signs. He's very tachycardic, for example, because of dehydration or because of pain or because, so you have to give bolus of fluid, okay, this is very important, either normal saline or ringer lactate, okay. Sometimes if you are thinking of bleeding, the second bolus, the new guidelines, they recommend to give what we call it blood, okay, or negative, or you can cross-match the patient and give him according to his blood group. And continuous monitoring is very important, okay, to categorize the patient as is he responder? For example, you give fluid and he responded. If he didn't respond, and then, or he just respond like the case that we discussed it yesterday, and then he drift back to and he deteriorate. So this is very important. What about now? We'll talk about each organ. Okay, as you can see here, liver injury. It is also, it's not that common like spleen, but when there is a significant injury, you may have spleen and liver. Okay, and for liver, it's considered like almost 1/3 of injured organ in pediatric blunt abdominal trauma. And usually most of the injuries are managed, as I mentioned here, non-operatively, okay, especially for those who are stable, okay. If they are remain hemodynamically stable and does not have any other injuries like bowel injuries or so they don't require what we call it operative intervention. But in case of severe liver trauma, where there is instability of hemodynamic status of the patient, this require immediate surgical intervention even before doing a CT. Okay, embolization. There is they've been talking about the rule of embolization in case of significant bleeding. And in children, it's not that widely commonly used, okay? So while immobilization is debated, to be honest with you, in children, okay, it may be an option for managing an active blush on CT scan. What do we call that? This is, as you can see here in the CT, you can see the liver on the, if you are looking at the screen on the left side, okay, and there is this is in the red circle in the center. This is the contrast, and which we call it like blush. They call it the radiologist, okay, which may help to do immobilization. And this is, like you can see, the hematoma, which is secondary to laceration of the liver. Okay, so in the liver injury, most of the time it is nothing, just observation. Okay, especially if he's hemodynamically stable and there is no other injuries, significant injuries. What about splenic injury? This is splenic injury. It's a very common. Okay, it's the most common injured organ in the pediatric abdominal trauma. And also, luckily, 90% success rate with non-operative management, which is very good, which has become the standard practice of management and achieve a very high success rate, up to 90%. And as I told you, you can see here also on the right side, this is the whitish, this is also blush sign, and there is some bleeding. I don't know if the pointer, you can see it. Okay. So also, as we mentioned, there is stages في السبلينيك injury, if you like, just to highlight before we go to the intestinal injuries. And this is like a grade 1 to 5. Okay, where grade 1, it is only like subcapsular, okay, hematoma, where the grade 5, it is completely shattered spleen, okay, with a hilar vascular injury and devascularization of the spleen. So this is very significant. So in the first 2, 3, what we call it, grades, okay, where grade 3, they have some laceration, but involving the parenchyma, and the depth is less, up to 3 centimeters. Okay, these can be managed non-operatively, especially if the patient is hemodynamically stable. But if he is hemodynamically unstable, you should go ahead and take him to the operating room. Also, intestine. Here, usually, sometimes we have to be careful with the intestinal injury, okay, because the detection of the bowel injury, it's a challenge, okay, for some physician, and bowel injury is not always evident at the initial presentation, and may have a delayed presentation, okay, and secondary to perforation, okay, and for this reason, it can can lead to ischemia, and the patient will present with abdominal pain. So you have to consider this, and you have to do a CT to in the clinical context, with a serial exam being the gold standard, and you have to involve the surgeon if you have a doubt, okay, by doing a surgical consultation, which is mandatory for suspected bowel injuries, given the necessity for operative intervention. As I mentioned, the DBL in intestinal, it has a good sensitivity, okay, because of the food material or some bile or whatever, that can give an indication for bowel injury, and then surgical consultation should be done as early as possible. Duodenal injury. Duodenal injury, it's like very rare, but may be associated with other distracting injury, or sometimes child abuse, okay, and because of the location of the duodenum, okay, and it is in the retroperitoneum, and it is protected, so duodenal injury, it is really rare, okay, And I've never seen through my training and my work, seen any patient coming with a duodenal injury unless this is a very, very significant abdominal and penetrating injury. Okay. طبعا in some cases it's been reported with a child abuse because of the direct fist to the abdomen, the upper abdomen. Diagnosis and management طبعا, of course, early CT scan with oral contrast is very crucial, and with non-operative management for hematoma and surgery for perforation if there is a perforation. Okay, what about pancreatic injuries? It is very rare, also the same as duodenal, okay, and pediatric. With it is usually the percentage is around 3 to 10%, okay, which is a rare injury, and it's require a very high index of suspicion. And CT as early as possible should be considered, okay, and the serial of amylase labs measurement are helpful with ARCP providing early evaluation and intervention for pancreatic injury. So, and the management usually should be طبعا زي ما قلت, as I mentioned, amylase should be doing a serial amylase, because in some cases the initial serum amylase may be normal even with the complete transection of the pancreatic duct. So this should be considered, okay? And if the injury is still suspected, as I mentioned, ERCP can provide an early evaluation and a possibility of intervention for pancreatic injuries. What is the treatment? Management, okay? There is a lot of debate, okay, and it's not well defined. Secondary to, because this is rare, okay, and for this reason, non-operative management point to save the management of the pancreatic injury with no morbidity, and sometimes there is what we call it pseudocyst is expected to have it in some patients, okay, with this significant injury of the pancreas. But the management, it depends on the surgical consultation, okay, and but both surgery and non-surgery were advocated and being and this will go back to the surgeon decision. This is for pancreas. What about aortic injury in pediatric? How common aortic injury in pediatric? Okay. Of course, blunt abdominal trauma, okay, can cause the abdominal injury, but it's really rare in children, okay, in pediatric population. And there is, in one study, it's been mentioned that since 1966, there was only till the study, they published the study in 2013. That means more than 50, 60 years. Okay, it's been mentioned that only 17 reported cases in the literature of pediatric trauma patients with aortic injury. Okay, and this is mainly with the seat belt. Sometimes they said with a significant fracture, chance fracture, what you call chance fracture associated with the seat belt from motor vehicle crashes are usually the common mechanism. And CT is the most important for the diagnosis, and the treatment typically involve usually in these cases open operative repair with vascular technique, endovascular technique as a consideration. I didn't know. I think I missed to talk about the renal trauma, but also in the kidneys, the renal urges should be suspected in a patient with the, if there is a gross hematuria, okay, and or microscopic hematuria with associated hypotension. So renal trauma, and the majority of these cases result from motor vehicle crashes or falls or sport-related trauma. It's like other organs, like spleen and the liver. If there is the patient hemodynamically stable, so there is no surgical intervention, and the patient can be managed non-operatively. Okay. Child abuse. This is a very important. Abdominal trauma. It is a very common. And it's the second leading cause of abusive trauma mortality, okay, in a child who suffered from abuse. And the risk factors usually like poverty, male gender, and young age increase the risk. And when you have similar cases and family, they have these risk factors, you should consider child abuse. High suspicion, high level of is necessary for injuries that do not match the history provided. And this is what we mentioned it yesterday. What about the pelvic fracture? As we mentioned in pelvic fracture, the presence of pelvic fracture and tenderness can indicate a fracture. You can just feel the stability of the pelvis, okay? And if there is a tenderness, you should consider. And luckily, most of the time, it is like in the superior ramus, inferior ramus, okay, which is the weakest bone in the body, okay, but the management is non-operative. Okay. Also, abdominal tenderness can predict some, also consider pelvic fracture. The mechanism usually motor vehicle ejection from the motor during crash. It's a predictive factor. And as I mentioned, the management will be. Also, one of the important factors actually in management of blunt trauma, because there is a bowel and it's preventing of infection. This is not only in abdominal blunt trauma, but in any kind of trauma, and even in any medical or surgical cases presented to the emergency. So prevention of infection is a key aspect of initial resuscitation. So implementing strict infection control measures like proper hand hygiene, use of personal protective PPE, and disinfection protocol can help to reduce the risk of hospital-acquired infection and improve the patient outcome. I think this is my end of slide. So a summary of pediatric abdominal trauma. This is like a summary. It's been, we have to adhere to the ATLS guidelines, okay, in managing these patients who are prone to abdominal trauma, and focus on a clinical acumen. يعني check if you have any doubt of abdominal suspicion, okay, or acumen, like your الفطنة, يعني you think there is a abdominal injury, you should involve surgical, and you should go ahead for some labs and imaging and all these things, especially for a stable patient. Non-stable, let's just involve surgery and take him to OR. Non-operative treatment is often sufficient for solid organ abdominal injuries, while hollow organ injuries require surgery. Hollow organ, like a bowel. This is what we mentioned. Continuous re-evaluation is essential in non-operative care, and transfer to specialized centers should be considered for multi-system trauma. Any questions, guys? Most of you, they are giving comments. Someone was asking. Somebody was asking about waddle stride. Well, to be honest with you, I don't know what is waddle stride, so I have to be. You can check it online and see what is it. What else? Okay, عليكم السلام, عليكم السلام. طيب, no question. Thank you very much. Let me see the question. Okay. Sure. طيب. This guy, his name anonymous attendee. He keeps asking for the lecture to be on YouTube. Okay, promise you it will be in YouTube as soon as possible. Okay, and thank you very much all. I think now Dr. Saleh al-Shihri, he will present. I will leave the microphone for him. Dr. Saleh, you can start, please.
Thank you, Dr. Muhammad. Jazakallah khair. Just give me brief to hold my طيب. السلام عليكم ورحمة الله. الصوت واضح؟
واضح جدا.
السلايد موجودة ها؟ طيب. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم. I'm going just to little bit speak about the airway management in pediatric emergency. I will talk brief, inshallah, and within next, inshallah, 40 minutes or 30 minutes, inshallah. Management of airway in pediatric. Here we will discuss some clinical scenarios and variety of airway management. Also, we will discuss the video for using laryngoscope and aim to help visualizing of difficult airway. Speak about the bag mask ventilation and RSI and difficult airway. Let's discuss here briefly this case. It's a 9-month-old boy brought to the emergency by the ambulance with a history of fever that present with seizures at home. On arrival, patient has a stopped seizure, also no breathing, and oxygen saturations were dropped to 80. Then after a while, when we reach to the resus room, it was being dropped further to 75%. So briefly, what can we do here? Just brief. Okay, primary survey. What you want from the airway? What do you want from the airway? Yes, airway. What do you want from the airway? Just we need to open the airway and just remember, and make it patent, and there is no foreign body or anything can obscure the airway. Remember here, it's something little bit unpleasant experience when you have child who's been apneic or unable to breathing. I'm sure يعني إنه الجميع ما يبغى يشوف المشهد هذا. it's hopefully إنه everything will go smooth in my shift, at least in my shift. Remember here, when you have a difficult airway, don't be afraid to call airway expert. Even if you have experience in the emergency for 10, 20, 30, 40 years. Don't be afraid, don't be shy to call expert people there. Airway management here process, positioning the head, make sure the head and the positions, open the airway and be careful if the patient have trauma or any suspect of cervical injury. Open the airway. If there is you cannot hear or you cannot detect any air movement, you may this have because of the secretions, heavy secretions, or foreign body maneuvers, or some bleeding there. We need to remove it. Consider the airway adjunct to keep airway open. Use oxygen if breathing at risk of hypoxia. Suction if we need it. Bag mask ventilation. If the patient initially been apneic, we need to help his breathing. Consider here 2-person and stabilizing SEEP spines in any trauma patient, because cervical injury, we cannot rule it out here. Endotracheal tubations with rapid sequence intubation, consider it here. Reassess, always reassess every step, with every step, reassess with each step in the management of the airway. So the position the head and open the airway, here we need to keep the midline. We need to avoid that's happened frequent in the resus, that we are not aware about, that we are doing a lot of maneuver of flexion and extension for the baby or for the pediatric patient. So we need to avoid excessive flexion and extension, especially with the trauma patient. Don't be aggressive. And the reason just to intubate the patient. Consider 2-person to stabilize cervical spine here. If no history of trauma, you can use towel under the shoulder to achieve position here. And you can see here, the jaw thrust is very useful here in children and relieving the obstructions. Here we're using the towel, so you can visualizing the vocal cord and can be intubated easily here. Airway adjunct here, other than definitive airway, here we have the oropharyngeal airway. I'm sure most of you, they are expert and they have good experience how to using the oropharyngeal airway. You may need to use it in unconscious patient to keep the tongue from the occluding posterior pharynx. Cannot be used in patient with intact gag, because you will induce gag and the patient will be vomit. On other side, we can use simple airway adjunct, which what we call it nasopharyngeal airway. So make sure it's from tragus of the ear, about the size of the nasopharyngeal airway. Use it in semi-conscious patient to keep the airway. Good things إنه ما بتأثر على موضوع الجاج reflex here. Excellent for use, especially for overdose patient, an adult who has been toxic or semi-conscious. The good things with nasopharyngeal to not induce the gag reflex here. Avoid and suspected of basal skull fractures. This is one of the contraindications for using of nasopharyngeal. Here's a video, short video.
Oral airway insertion. Place an oral airway in an unconscious patient who has no gag reflex. If possible, use a tongue blade to depress and displace the tongue away from the roof of the mouth. Insert the airway following the curvature of the tongue into the oropharynx. An alternate approach is to insert the airway upside down. As the tip of the airway reaches the posterior wall of the pharynx, rotate the airway 180 degrees into the proper position.
For me, personally, I like to use the rotate methods without using the tongue depressor. So just insert it the opposite side, then rotate it inside the mouth. This most of the time I'm using this maneuvers. This is about nasopharyngeal airway. Same, we'll rotate it. Bag mask ventilation. Here are the steps here. We need to make sure the size for the face mask. Choose the bag. We have variety, adult or pediatric or infant. And the smallest one, it's the neonatal size. We need to attach the back of the ambu bag to the oxygen. Use EC, like what we see here. The C from the hand with the thumb and the index, so that can make a sealing for the mask on the face of the child. And E, the just for to hold the mandibles and push it up to the C side. Of course, this method needs to be highly careful if you are the only one in the rhesus area with the trauma patient. So you need to avoid any cervical movement with this patient until some help from other healthcare in the area to help you to use the 2 persons and keeping the ventilation of the patient. Bag mask ventilation here, it's adult size, it's from 800 to 1000 ml. Pediatric is 450 to 500 ml. Small child, 290 to 400 ml. And neonatal is from 80 to 120 ml, which is the smallest size in the rhesus room. Be careful about the size of the bag. Sometimes I'm seeing in many centers that you're using neonatal for bag the child. And this is maybe will cause worsening of the hypoxia and brain injury. So make sure about the appropriate size for the child. I mean, using bigger size, better than to use smallest size. EC clamp that hold the mask of the face, and E to pull the chin and mandibles to the mask and make clamp using 3 finger in the jawline. EC clamp, an infant avoid pressure on the submental area. So this is one of the most dangerous when we're doing bagging, when you're doing excessive pressure to the neck or submental area, that will be suffocate the child, prevent the air go to the air here. Only 1 finger may be fit on your line. Back mask ventilation here, too much cricoid pressure may lead to the airway obstruction. If no chest rise here with bag mask, lightening the cricoid pressure here, control the rate and volume, give only amount of air needed to get chest to rise. We like to use sometimes 1 to 5, like for example, giving bag slowly inside inhalation, then slow release, say 3 times. So you can just give enough for the to the breathing and good tidal volume to move with the patient, giving time to exchange the air. Maximum ventilation rate for neonate is 40 per minute, infant 30, and children's 20, adult 12 to 15. Slow rate are the best. Too hard, too fast, this will make problem and gastric inflate and can the patient having aspirate later on. Endotracheal intubation here. Preparation is the key. Equipment and staff be ready. Bag mask, period oxygenation should be ready before arriving the patient. Consider RSI also to be available there. Equipment, suction, oxygen, ET tube. Stylet is very important. Sometimes we miss it. Stylet. And the stylet we need to be at least minimum 1 centimeter from the end of the tube. Pediatric McGill forceps. I'm hearing someone write 40 to 60. You need to avoid fast breathing. Sorry for that. My computer sometimes gives me So 80 tube, stylet, and pediatric McGill forceps, and carbon dioxide detector. Calculation of 80 tube size, chart based on the weight or length, measurement from length-based resuscitation tape by the Brosley tape. Greater than 1 year of age can be calculated. I like to use this equation, which is called quarter age plus 4, ربع العمر زائد 4. Quarter age divided by 4 plus 4. This after 1 year. Other method, but this is non-sensitive, which is using the width of the little finger or the size of nasal width. But this too is not sensitive, and most of the time is inaccurate. And alhamdulillah, most of the research they're having Brosley tape, and the calculation is easy for them. Premature infant, use from size 2.5 to 3. Newborn, 3 to 3.5 tube. Age of 1 year, need at least 4 millimeters. Don't use less than 4 after 1 year age. Usually 3 to 3.5, it's for neonate. About the uncuffed tube, 1 year, 4, it's usually 10 kg, 5 years, 5, and for 8 to 10, 6. Brosley tape here, it's available everywhere, available in the market, available in the Amazon. It's around like $20 or $25. You can keep it all in the pocket. Measure from head to the heel of the patient. It's good for the weight between 3 and 3 years, 3 to 36 of kg. What's the difference between cuffed and versus uncuffed tube? Size just only half millimeters, less than standard formula for cuffed tube. When you do use it, a cuff tube, any patient that may require high pressure to ventilate, and actually I'm using it for all patients above 1 year. All the age cuffed. Cuffed is very good. Can be used in any critical or injured infant or children's. Studies show that same frequency of subglottic stenosis. If you're worrying about subglottic stenosis, it's almost the same between cuffed and uncuffed. They have the same ratio. The cuff tube here, it's age divided by 4, quarter the age, plus 3.5. Uncuffed, same equation, quarter age, plus 4 instead of 3.5. Laryngoscope blade size, 0 all mainly very difficult to intubate with 0. It may be only for premature and young neonate. That's 0. Because it's very short, and not advised to use it or try it after 1 month of age. Miller 1, it's fit for all age group. The good things with Miller, it can go and pull the epiglottis very well, and we can see, especially in the age group. So most of the time we are using Miller size. Mac, if you go beyond the epiglottis and pull it up, but this is usually for adult patients, because the airway is soft and floppy and short. That's why most of the time we are using Miller. Miller size 2 for the patient from 13 to 24 kg, Miller 3, 25 kg and above. Macintosh may be used after 2 years of age, but personally, I'm not feeling comfortable to use Mac at pediatric age group. You try to use it with the school age, like 7 or 8 years. It works sometimes, or in the adolescents. The problem with too small blade can get you into trouble. Depth of the tube, sorry, because I'm having some viral, so I think everyone getting this flu everywhere hear it. So maybe the voice is not good. Now, depth of the tube placement, watch focal cord marker, go to the past the cords. Depth of the tube placement in centimeter can be calculated as 3 times of the size of the tube. Depth can also be determined by use of the length-based resuscitation tape or by using an illuminated 80 tubes. Confirming of the 80 tubes can be by the clinical assessment using 5-point, the upper chest, and also plus the epigastric area. We need to listen to that with the stethoscope. carbon dioxide detection or monitors, esophageal detection device, bulb or any syringe, just to make sure there's air or no air coming with you. Chest X-ray position of the ET tube here. And if you see this X-ray, it's almost at the tip of the cardia, so you need to a little bit pull it up. So this patient most likely will be having more air in the right side than the left side in this chest X-ray, so better to pull it up. And also you need to confirm also by pulse oximeter. Pulse oximeter is not a good tool to confirm the ET tube place because it takes from 30 up to 1 minute until dropping or improving in the oxygenation. About the complication of endotracheal intubations, everyone know about the guidelines of DOPE. DOPE, it's meaning a dislodgement of ET tubes, especially during the transfer. Or it can be obstructions by secretions or some movement of foreign body there, or fail of the oxygens, not giving enough oxygen. Pneumothorax patient, because of the excessive ventilations, can have pneumothorax there. Or equipment fail, like ventilator switch off. How about foreign body aspiration? I'm sure nobody like to see it in the emergency because, you know, it happened sudden. The morbidity and mortality is high. Sometimes very, very difficult to oxygenate the child. You will see panic parents shouting, everyone shouting. Child was doing very good 5 minutes ago, and now almost his apnea is not able to get his breathing. So better to start it at the site by the midvac or by the paramedics if they arrive early by the Red Crescent there. Begin with the BLS maneuver. An infant, we can do the back blows and chest thrust 5 times. In the child, if conscious abdomen thrust, Helmut maneuvers, 5 cycle. If the child lose his consciousness, we'll go with the chest compression. If that above failed, we'll go to the ALS for advanced life support. Use McGill forceps to remove the foreign body. Sometimes we go to the surgical airway if that's failed also. This is show by using gyroscope here and use McGill forceps. See how they handle it, the McGill forceps, and to catch the foreign body and to remove it. So what about rapid sequence intubations? Rapid sequence intubations need to be prepared. Will need to be oxygenation before starting giving the medication. Be planned for pre-treatment. Prepare for paralysis with induction. Be careful about the protection and the positioning of the airway. Prepare yourself for the worst. Also scenario there. The placement of ET tubes in the trachea and post-intubations management. And this is all will be depend individually about clinical scenario. Every clinical is different than the other. Pre-oxygenation, we need to give the patient full oxygens, try to make the pulse oximeter for him up to 100% before you starting intubation. Remember to implant become hypoxic quickly. The child having high metabolic rate versus adult, so they need to provide them with oxygens all the time. High flow nasal cannula, 5 to 50 liters per minute, can prevent hypoxia during the apneic period here. So high flow, one of adjunct ventilation that given to the kids and improving their airway and avoiding the intubation several times in many situations. by giving high nasal cannula. Alhamdulillah, this machine improving a lot and minimizing the risk of intubations for kids. The net pressure here in the alveoli is subatmospheric. The child so getting less oxygen. So we achieving apneic oxygenation with using nasal cannula and non-breathers and non-breathing patient. The oxygen will fill the reservoir of the nasopharynx. Children and adult, usually from 10 to 15 liters per minute. This will be considered as high flow. For infant and toddlers, it's 5 to 10 liters per minute. Pre-treatment, atropine, it's not using frequently. Sometimes using to dry the secretion in the mouth. The dose is 0.02 milligrams per kg. Using atropine is not routinely used, but just to stabilize the sympathetic nerve and avoid the bradycardia. Even there is no definitive study about the atropine will that's control the bradycardia patient with intubations. But there is no risk for that if you can use it with appropriate dose. Use an infant less than 1 year. Children 1 to 5 for receiving sucks or multiple dose of succinylcholine. The minimum dose is 0.1 and the maximum is adult one is 0.5 milligram total. Sedative selections here, we have variety of sedative selection in the emergency. If the patient is hypotensive, of course, you need to avoid the midazolam or diazepam there because it will be further hypotensive. Ketamine is a good option here. Bronchoconstrictions, also good option to use ketamine. Ketamine is also good as a bronchodilator if using a proper dose. Head injury without hypotension, because still there's some concern about ketamine maybe causing intracranial pressure, but still no proved study about this, about ketamine. Ketamine till now is no definitive that can lead to the increased intracranial pressure. But until now, sometimes we need to avoid it in patients with normal blood pressure or high blood pressure or any signs of shock here because of the head injury. So alternative to that, using etomidate, thiopental, or midazolam. If the patient having head injury with hypotension, so no effect of or concern about ICP here, so etomidate or ketamine can be safely used here. What about neuromuscular blocking? What in your practice? What kind of neuromuscular blocking do you like to use it in your emergency? Is it SACS or Ecronium? SACS, Ecronium. I hear a lot, many people, they are like using Ecronium, actually. Even the intensivist, when we come, they like to use the Ecronium here. And the advantage of Ecronium, it's almost very close, the onset is very close to the SACS. SACS is very fast, but having shorter duration, only 3 to 8 minutes. After that, patient will be moved. Ecronium is a good, and the doses, I like the dose also, 1 milligram. Whatever, it's onset 1 to 3 minutes and duration 25 to 35 minutes. Longer duration. The good one is a longer duration with, sorry. The longer durations here, 25 to 35 minutes. So it make me relax in emergency and can transfer the patient safely to the ICU or transfer the care for that. SACS, no, I need to repeat the dose, and many times the complications of long-term of muscle blocked can happen from the succinylcholine. So the good Ecronium is a good one. Anyhow, you can use it both. Ventilatory management, ventilatory setting here, many of the hospital, they have already respiratory therapists there. They will make you relax and he will calculate the setting. But overall, the ventilator setting are adjusted based on the patient clinical status, chest raise, pulse oximeter, peak inspiratory pressure, end-tidal carbon dioxide, blood gas analysis, selection of tidal volume. Here, methods based on the following generally: visible chest exclusion, simulation, normal breathing, audible airway entry, and less dyspnea. And the volume usually from 4 to 8, and sometimes you can go up to 10 ml per kg for the tidal volume. Airway management in trauma. Here the question here: will your trauma patient be able to maintain oxygen and ventilation? And what's the reason to that patient is not able to maintaining his ventilation there? One of the reason there is when you have a patient, trauma patient with less having GCS is low because of head trauma there, and he cannot maintain his GCS less than 11. Also secretions, bloody secretions, foreign body aspirations, all this can minimizing the patient able to have appropriate breathing. So do they need all definitive airway or not? All the patient, they need to intubate him immediately, or we can use other method than definitive airway. See here the problem with the airway trauma patient. Patient who having laryngeal trauma here. I think this patient is there's a heavy table full in his neck and make laryngeal trauma and the air leak, and having this progressive edema that we see it here. So laryngeal trauma, be careful when the patient have hoarseness or subcutaneous emphysema or bowel fracture at the neck of both. Prepare yourself for the worst scenarios there. If the patient is still having potent airway and you start to have surgical emphysema, you may need to be fast and secure the airway before the airway blocked like that. Parent patient also because of the inhalation, hot inhalation air, they may develop edema. So we need to secure the airway. Even the patient is breathing well now, but we cannot predict what will happen in the next few hours. Maxillofacial trauma, we have a problem with bleeding, tooth aspirate, bony fragment in the throat, swelling, secretions, heavy secretions, and thick secretions usually, especially with the clot blood, dislodged teeth in the oral area. And we can also, when we need to make definitive airway for the patient, is sometimes very difficult because everything being destroyed and we lost all the anatomical support there, everything floppy, fracture, especially with the mandible, maxilla, mid-face fractures. It's one of the nightmare to intubate that patient. And once you predict this patient or you have some receiving call, the patient will arrive to the emergency, you need to call the expert anesthesia consultant and the ENT to be accompanied with you. So predict the worst with those patients. Problem also with the airway trauma patient, airway obstruction. It's also one of our nightmare with trauma patient. Brain injury with low GCS, we need to be quickly and secure the airway there. CNS depression, altered breathing mechanics like rib fracture, flail chest, pneumo or hemothorax, and cord injury. That's with the lower airway, you need to deal with it. Predict the difficult airway. Here we call it Lyman. Lyman, L from L is mean looks. E for evaluation of 3, 3, 2. 3 from 3 finger between the incisors. 3, another 3. The second 3 is the 3 finger between the chin and the hyoid bone. And number 2 is the finger between the thyroid notch and the floor of the mouth. 2 finger. So if that one there, that meaning inshallah will be easily to intubate him. LEM, M from Malambati score. That we can see the soft palate, uvula, anterior and posterior biliary pillars. Grade 1, class 1 and 2, that's the easiest for intubation. Above 2, no, you need to call some airway expert to be with us. O obstruction and N neck mobility. Here also again, don't forget to call the help, to call for help. You may need the most expert person in the hospital to be with you here. Airway management here for the trauma patient, we need to be careful about stabilizing the airway, midline the air, stabilize the cervical, don't allow it to be moved. We will you should predict the worst scenario with his cervical. Here is the two person using and to align the air, the neck, midline it, and to be quickly intubate the patient. This also is not pleasant or not good expert to intubate the patient with two person, but you the most expert with securing the airway, like the consultant emergency, need to be done by him. What about non-definitive airway? This is what we call it. You know what's the name of this one? About the LMA, laryngeal mask. The good thing, this one we can occlude the esophagus and the air coming from the tube here, so oxygen, so it can be easily inserted. It's not definitive airway, but can be temporarily securing the airway until later on to have a definitive airway there. This is what we call it combi tube, which is having two balloons there. One will be dislodge the esophagus here, and one will be in the oropharynx, and the air will coming from the bed to the lung. That's what we call combi tube. Definitive airway in trauma patient, either using endotracheal tube, nasotracheal tube, and surgical airway. Nasotracheal should be avoided with any head or suspected basal skull fracture. You need definitive airway management if non-definitive airway cannot be maintaining the oxygen, or patient have difficult airway management and difficult to maintaining the ventilation. What about pre-arrival checklist? What about pre-arrival checklist airway for trauma? Number one, oxygen mask and nasal cannula available and connected to oxygen. Oral airway available. Number three, suction available and running. This is before patient arrive. Number four, the range of a scope plate and handle functioning and available. Number five, endotracheal tube and stylet available and ready. Number six, extra tubes and stylet available because we may fail with one, so we need the other one. Bougie should be available. Bougie is very nice for the difficult intubations, or if you want to exchange the tubes, there is different size for bougie. Backup of supraglottic airway available. Monitors and video laryngoscope available there. Bag valve mask and with ET carbon dioxide available. Also prepare for the instrument for cricothyrotomy. Should be available before trauma patient arrive. Pre-induction checklist, pre-arrival checklist completed. Airway plan confirmed with trauma and ED with emergency physicians. IV line, we should test it before the patient arrive and should be functioning. Rapid sequence intubation medication, and the dose is drawn up already there. You can predict the doses by patient age before arrive. Cervical spine and line stabilization maintained. Pre-oxygenation with 15 liters per minute and nasal cannula at 5 liters per minute. Patient positioning and optimized. And the blood pressure cuff on the opposite arm should be ready. Appropriate size also of the cuff, not any cuff be used. What about the age? And use the appropriate size of cuff on the opposite arm of the IV line and connect to the pulse oximeter. This is about using surgical airway. When you use the, put your, you should mark about where is the cricothyroid membranous. This is your marker. how to use it. Need to be practice. Try most of the time to child below 2 years or under 2 years, because the carotid fissures is very close there. So if it's okay to be bended, tell the expert, the ENT, to be arrived. So better to avoid it, to be done by the emergency, because of the high risk of it's having small structure and the fissure is very close to yours. This is the video for good for gyroscope. It's simple, and I'm sure everyone is already practiced to the gyroscope. Need actually to be practiced all the time, not only 1 or 2 or 3 times, because when you have crisis or very sick patient, sometimes if your hand is not you're not that expert with that one, you may face a difficulty there. So once you are working the shift, try to use it and see how to work with you, and you be practice frequently there. Need all the time use their own stylet, so I can guide the tips where it can go, because it's difficult to use it without stylet. It's very, very difficult. Sometimes if the stylet, their own stylet is not available there, we can use our own stylet, the small one. You can put 1 or 2 together and make the tips 1 or 2 centimeter from the tip of the ET tubes. Make it like L shape. So this one, this maneuver, you can be okay, and you can use the gyroscope. Thank you so much for your listening to me, and I'm happy to receive your questions. Thank you so much.
Thank you, Dr. Saleh. Dr.
So-
Saleh, there is some question for you, Dr. Saleh.
Okay, I'm just following. Okay. Do you use video laryngoscope usually in the trauma patient or not? Yeah. Especially with the patient when traumatized and you have a lot of secretions. Gyroscope is very nice here to use it, because sometimes you cannot open the mouth, and the good things with gyroscope, you can maintaining the cervical line there. Melanectomy, we use it, but the problem with the melanectomy, you can't use it with unconscious patient, because you need cooperative patient. 332, this for adult. في question ثاني بعده. طيب شكرا جزيلا، جزاكم الله خير جميعا.
Thank you, Dr. Saleh. طبعا we'll go for break. We'll be back inshallah 10:15 inshallah.
Okay.
Allah Good. Today I will cover a very important topic. You can face this one or encounter this one in your area. That patient present with the eye trauma. So you have to be more familiar how to deal with this patient. When that time you have to be refer the patient to the OFTA. What patient need emergency to refer to this patient to OFTA, or you can be you can discharge the patient and you can follow the patient in the OPD. As you know, this ocular injury is very common to be seen this patient in the emergency department, and one of the important cause of that can be preventable blindness in children. Uh, it's very common. You can see this patient in the ER. Eye injury have to be wide variety of the presentation from pediatric population, depend on the patient age and the mechanism of the injury. Maybe that injury is subtle. You cannot find that's the cause of this one, or maybe there is foreign body or minor eye trauma, or maybe he has some vision threatening for that patient. And also maybe just only isolated ocular trauma, as maybe as isolated, or maybe as part of the polytrauma with this patient. In United States, there is recorded around 1 million cases eye injury. Most of the cases is children less than 18 years old. 7% of this one end up by the significant impairment for that patient. So many related to the cases presentation, the mechanism secondary to the sport, especially for that patient adolescent age. As you know, that's boy 3 times more common than girl. What's the common mechanism can make less injury for that patient? Usually as sport or household or domestic or vehicle or RTA, or maybe he's falls from height. Around 20% of that cause of that mechanism is projectile object, can be secondary to body part, around 12%. Blunt objects is around 10%, and sharp objects around 9% of that causes of that mechanism for injury for the eye. Also, that firework, especially in the some events, can cause that eye injury. Younger children are at risk for accidental eye injury in the household during that recreational activity. Older children born to the sport, so he's related that injury to that sport because that, especially in the age of the adolescent. Also, it's very important to categorize that mechanism depending on that age of that patient. It's very important to be more familiar for the anatomy of the eye. You can, this is the cornea, okay? This is the part is anterior chamber. This is the posterior chamber for this patient, okay? This is the lens. This is the iris for this patient. And this is the central of the Schlemm canal that's make connection between for that intraocular fluid connected and past with obstruction that we can cause increase the intraocular pressure. This is the ciliary body. This is the vitreous part and choroid and retina. This is macula. Okay. So if you want to categorize this, depend on the periocular and ocular, you can find the eyelid and lash and orbital bone. Ocular, you can have to be more familiar with conjunctiva. The globe for this eyeball without bandages, this is like sclera and cornea, anterior chamber, and iris, pupil, lens, retina, and nerve. So you have to be more familiar for all that part when you try to examine and label and reporting if there is any trauma. So we can see many different laceration related to the eye. It's very important you have to be more familiar for this one. It's very important to know if there is marginal laceration or this is deep laceration can involve this upper eyelid, or there is distorted that's pupil. You have to be familiar if there is any foreign body in the inner area of that upper eyelid. If there is any abnormal eye movement, okay, there is any tear in the iris, okay, there is any hyphemia for this patient, and there is any subconjunctival hemorrhage for this patient, okay, or there is an epithelial loss for that patient with the iris or mist. So you have to more familiar with the laceration and how to describe this one. The energy of that anatomical laceration is very important to how to describe. When you try to start to examine the patient, you have to start from the preorbital structure. You can find if there is any eyelid laceration. You have to describe this one. It is a lid margin laceration. That one will be require urgent consultation for that of that. Canicular laceration for this one. This one, if there is any canicular laceration for this one, this is very important, especially this is in the medial epicanther for this one. It's very important to be referred this patient to ophtha and consultation. Periocular ecchymosis is one indicated to go for consultation to the ophtha. Also, we have to skeleton for the orbital. It's very important to describe the orbital wall fracture if you are uncomplicated. If you're uncomplicated, you can be followed by 24 hours. Muscle interruption for this one is very important. Continuous, maybe affect the cardiac. You have to need the cardiac monitor. Maybe can be or can cause a bradycardia as a reflex due to the ocular cardiac reflex. Compartment syndrome is very important, and it's very emergent canthotomy for this patient. Patient, he has a foreign body. If it's superficial, can be followed by 24 hours. Optic nerve damage, also very important to be sure. Also, if there is any ophthalmic artery injury. Also, for a globe close, that's like if there is any conjunctival injury like abrasion, laceration, corneal injury, abrasion, also severe thermal or chemical pain for this patient is very important. Also, that anterior chamber, you have to be described if there is hyphemia for this patient. So, like this patient, you have to be elevate the head on the bed. If it's minor, less than 1/3 of that anterior chamber, can be followed at 24 hours. Also, the iritis for this one can be followed within 24 hours. Scleral injury like abrasion, posterior chamber for this patient, or like lens dislocation, retinal injury for this patient, like vitreous hemorrhage or retinal tear can be or detachment. Also, that's that very important that globe open. If there is globe open, is like conjunctival laceration. You have to proceed for no, don't further proceed of examination. Just stop. Keep the patient very calm. Consult immediately for that ophtha. Also, if there is laceration in the cornea, okay, sclera, it's very important. So you have to more familiar, and also the zone of the eye you have to more limited. You have to be more have more familiar for this one. Zone 1 is limited to the cornea. Zone 2 from the limbus to 5 millimeter. This is the zone 2. Zone 3, that's after or beyond that 5 millimeter from the limbus. So this is the zone 3, zone 2, and zone 1. Zone 1 is the cornea, zone 2 from the limbus to 5 millimeter, zone 3 from 5 millimeter to beyond this one, that's for the rest of the sclera. How to approach for child with the eye injury? It's very important. You have to be more assessing for pediatric ocular trauma by history started. You have to document how's the mechanism of injury, time of injury, place or the setting of injury, and the caregiver for that time of injury. What's given for this patient, how to manage this patient. It's very important. Sometimes the non-proper management can increase the severity of the symptoms or that's can make that prognosis is very poor, especially for rupture glue. Initial intervention is given at the scene of that injury is very important. That's any possibility for a retain foreign body is very important. Also, you have to ask about what's the past medical history for this ocular. For this patient, maybe he's using glasses for correction of that vision for this patient, correct the error for this, and also maybe has any change of the vision after trauma or decrease this vision. What you can see, like flutter or flash or fire. What's the important to ask about this patient for this history? What is the time of the mechanism of the injury? Consider the impact, velocity, and based on the mechanism. What's the cause of the injury? In cases of that chemical exposure or the pain, or he was the exact causative agent for this one. What's the what was that eye protection used for this patient or not? What was that baseline vision prior to that injury? It's very important. Does this patient wearing glasses or contact lens? It's very important, especially for that when you try to examine if there is any cornea abrasion or not. Does this patient wear, what are that current symptoms? There is vision change, photophobia, foreign body, sensation, and there is any eye pain. What is the past medical history? It's very important. Like patient, he has hemoglobin, patient, he's maybe sickler. Okay. And also any past medical or past surgical history for this patient, especially for that eye surgery. How to examine the patient? You have to be perform non-contact with that aspect of that examination first. Then you have to observe, and if this patient by inspection, if there is any suspicion of the rupture glue, don't touch eye or by any surrounding tissue of this one. You have to keep the patient very calm, assess that visual acuity in each eye separately in the age appropriate manner, assess the pupil, record its shape, size, and reaction to the light, assess the ocular motility, need to examine the lid and the orbit, examine the conjunctiva and sclera, and also if there is any laceration or any foreign body, examine the cornea. If there is any abrasion or laceration, use that fluorescein test if possible. Examine the anterior chamber depth and clarity, and patient is hypobone for this one, or hypemia, or shallowing of the anterior chamber for this patient. Assist for the red reflex is very important to evaluate bilateral and compare bilateral if there is any change or absent. Dilated eye if need, and examine the retina or fundoscopy for this patient. Visual acuity is one of the important screening in the AR to be sure this patient there is any defect or not. But is considered in the vital signs for eye examination, is more reliable in children age more than 6 years. For children between that infant to up to 3 years old, you have to make good assessment or screening child by ability to fix and to follow. What recommended visual acuity testing chart for children aged from 3 to 5 years are can depend on LA or samples or TEP chart for this patient. Children more than 6 years should be visual acuity tested by the Sloan letters. If the verbal child visual acuity is too poor or to read that's age appropriate chart, what you have to do, you have to go descending order for visual acuity. There is an ability to recognize the close object or not. He can count the finger, he can recognize the hand movement, or at worst scenario, he just for perceive light or not. So you start from the chart, then go descend to find the worst scenario if he's just only just perceive light. This is the LA samples for this one from, you can testing this from 3 to 6 years old. And this is Sloan letters. It can be used for patient is more than 6 years old. You can testing of the visual acuity for this patient. Red reflex is direct ophthalmoscope 2 to 3 feet away from that patient. Both eyes are visualized in the same time. Normal red reflex represent a clear and pupillary axis. Unequal reflex or no reflex or white reflex indicate that's urgent to call the ophthalmologist for that assessment. External inspection for globe examination, look for asymmetry of the size, and also of this patient, of the ophthalmos for this patient, large globe that's caused by elevated ocular pressure. Also, you have to examine the pupillary examination, any quality of that side or symmetry of that shape, or it should be both urgent for ophthalmology referral. What test you have to do for patient from the infant to 3 years? That's fix and follow. This one, that's test just perform in the child. He's sitting with the parent or caregiver lab, and the examiner showing the child different toy or interesting objects, and note that he attention span the child is very short, so it's maybe challenging and to keep the child very engaged with you. So sometimes it may cause some difficulty to examine to follow that object. Examine the eyelid. It's very important. Begin with the examination and palpating of the orbital rim. Don't be put pressure on that globe during that examination, especially for that open globe injury if suspected. If there is any ptosis or ecchymosis or swelling or laceration, is the essential component of the eyelid examinations is to first that upper eyelid to rule out any injury to the foreign body. Also, if there is any laceration in the eyelid, maybe sometimes very deep and go and penetrating complete layers of the eyelid and approaching that eyeball, maybe causing some laceration or can cause rupture globe. You have to go gently using the cotton and try to effect this one and examine from inside. Orbital skeleton for this one and extraocular muscle is very important to evaluate that if any injury it may be involved that orbital skeleton or the extraocular muscle. Orbital wall fracture can lead to that ophthalmos, palpate of the rim or any tenderness, any step off or crepitus. If there is any inferior orbital nerve involvement, will be lose of the sensation to the lower eyelid. Also, they have to examine the extraocular movement, must be always be assessed by testing for range of movement on the follow the object in the H pattern, like this. Eye movement, you can, this is the H pattern for this one. This is the lateral superior oblique muscle. If you can looking this side, lateral rectus muscle, and you can looking to the nose, to the lateral, okay, inferior. This is the inferior rectus muscle. You cannot looking to the nose. This is medial rectus muscle or inferior oblique muscle. Also, in this way, this medial superior rectus muscle for this one. So you have to examine all that direction to be sure this all that extraocular muscle is intact. After finishing from that this one, you have to go for conjunctiva. You know, this is thin membrane is covering the posterior lid, palpebral, or this is pulpar for this one. If you want this anterior sclera, okay. Frequently injury causing erythema to the eye. Most conjunctival foreign body is loaded in the upper eyelid. Note that the presence of that conjunctival hemorrhage is very important. If it's more covering, that's more 50% of sclera, consider to open globe rupture, and you have to consult the ophthalmology. Sclera is one of the important part to have to be examined. The sclera is that's white of the eye, covering that's conjunctiva, suspected of the sclera injury with the eyelid or laceration. The eyelid should be well retracted to be assessed all the sclera. If the sclera area of the sclera appear darker, that's meaning there is indicate there is deeper laceration and with the exposed pigmented choroid. Okay, so maybe think about the rupture globe for this patient. What about the cornea? Cornea is very important part of the eye. It's very important to be examined. The cornea examination begins with the bright light aimed directly to the diagonally and to the cornea to evaluate that presence of the foreign body or not. Any obesity for this one, like chemical or thermal injury, laceration, or prolapse of anterior chamber contents. Applying topical anesthesia such as the tetracycline, and then you can staining of the eye with the fluorescein should be as a part of your examination to cause this if there is any suspected corneal injury for this patient. Anterior chamber for this patient is very important to examine and to make good comment about this one. Visualize the anterior chamber for the depth and the presence of the foreign material or foreign materials for this patient, and any cell or any hyphemia for this patient. Iris and pupil is very important. 42 to uvea, and this pigmented layer of the eye and consists of the iris, ciliary body, and choroid. Examine the iris for any laceration or radiodialysis for this patient away from this iris, from the ciliary body. Tearing, there is any tearing. Any day shape or teardrop shape of the pupil suggests of the ciliary muscles disrupted and rupture groove. Lens is have to be checked for lens to see whether there is white light reflex suggested of the traumatic cataract. Retina is very important. Retina to have to be examined should be attempt to be in all cooperative patient and is often challenging in pediatric patient. Examination must be revealed that in case of non-accidental trauma, in cases of suspected non-accidental trauma, you have to consult ophthalmologic examination should be performed, ideally within 72 hours for that presentation. The slit lamp, as you know, is one of that important assistance tool for that ophthalmologist to be imaging of that eye. This can increase that 40 times that and assisting for detailed ocular examination. It can aid for that diagnosis of the minor lesion of the eyelid, or that's difficult to be visualized otherwise, such like foreign body or eyelids, sclera, conjunctiva, cornea or corneal injury, or traumatic hypemia or iritis, or this one, or the traumatic lens, or rupture of that, or discoloration for this one, or vitreous hemorrhage for this one. He's good. This part is related to the ophthalmologist. Now, from that examination, we will do visual acuity. We will go for eyelid and latch for the examination, as you mentioned in the beginning. Orbital skeleton, I mentioned for this one, and periorbital rim and extraocular movement, as mentioned before. So it's very important. Conjunctiva will be examined. Sclera, cornea, anterior chamber, iris and pupil, and lens. All that's what you mentioned, and that this one will be summarized in this table and how to dealing with and examine the patient. Then we have to report this one and make that's your finding in this table. If there is any defect, you have to mention which part, left eye or right eye, and then you make your report. Fluorescein helping to locate that epithelial defect for this patient. Application, you have to 1 or 2 drops. Sometimes can be associated with the anesthetic solution prior to the staining of the eye, can be very helpful. After staining of that cornea with the fluorescent fluid by under that covered blue light. Contact lens, sometimes you have to remove. If there is a contact lens, you have to remove before make that staining of that by fluorescent. Fluorescent staining is not generally recommended for patients with the ocular or chemical burn for this one. Any cornea abrasion will be visualized by as the dye is uptake in the area of that insult. That area of that uptake in the area of that fluorescence will be changed to be yellow. You can see which this is yellow for this one of the uptake by that fluorescence in that area of the picked area. So it's very important. So fluorescence staining is very important to perform the sitting in the ocular foreign body, and when there is any concern of the subtle globe perforation for this patient. The presence of the multiple vertical line of that dye uptake, like ice ring sign, it is suggestive there is upper eyelid for body, so you have to invert it, the upper eyelid, and looking for if there is any foreign body. Sciatic sign, this is very important sign for this, if this patient present with the sign, this is present with the an eruption globe. There is a bright green uptake surrounding that waterfall-like area with low uptake is important clue for perforated globe. Avoid the fluorescent if there is any obvious open globe injury. So don't you do like this? Okay. In that case, sometimes you use the like pH. You have to measure the pH, especially any patient exposed for chemical injury. Case of that chemical exposure for eye, it is very important. Very important. Litmus paper can be used for bedside to assess that pH from the fornix. The pH is normal less than 6.5 or more than 7.7 is aggressive eye irrigation should be performed. Also, if you didn't have this one, you can use the urine dipstick strip can be usually used if litmus paper is not available. The other important, this one, the ocular, it's very important to measure the pressure for this ocular pressure. Ocular can be used as tonometry can be performed in older cooperative children without the need for the sedation. Tonometry should be avoided if there is any open or rupture globe. It's very important. Imaging study, ultrasound, one of that's good modality for using for eye examination, focus to help to detect any abnormality in the lens or vitreous or retina or optic nerve or retrobulbar segment or even body abnormality. And focus intraocular foreign body can be seen and shadowing hyperechoic focus. So sometimes very helpful to also for detachment or there is any vitreous hemorrhage or any abnormality or any also can be give impression about the intraocular pressure for this one. The hand of the examiner should be rest on the patient forehead to reduce that pressure on the eye or eyeball. Also can be using CT scan, ocular CT scan for that open globe for any foreign body or orbital fracture or orbital compartment syndrome. MRI is contraindicated if there is any metal. Foreign body can be suspected and is not entirely ruled out from that at the presentation. So avoid if there is suspected if there is foreign body metal foreign body. MRI can be used for circumstances that's in which that's organic foreign body suspected but not seen in the CT scan. Let's start to make as a case scenario is very important. Patient present 12 years old boy was in the garage with his dad while he was drilling or starting to complain. He started to complain of pain, tearing like something was stuck in his eye. After your through history and eye exam with the version of that lid, you find what you find. This is foreign body, okay, and there is other one foreign body you can see here. So what you have to do, common problem presentation, foreign body, he present with tearing, conjunctival erythema, management, careful inspection, inverted upper eyelid as patient look down, remove the foreign body with the moistened cotton swab. May need to saline irrigation sometime. Consider topical anesthesia. Look for the corneal abrasion. Sometimes can associate with the corneal abrasion, and you can use the fluorescein to show this patient there is no any injury to the layer or epithelial layer of the cornea. consider that psychoplegic agent. You can sometimes to use the 25 to 27 gauge needle if you use very superficial and oblique angle to loosen foreign body at the edge of that cornea. If you didn't confident or didn't have good experience, don't do this technique. Immediate ophthalmology consultation if it's embedded foreign body or intraocular. Case number 2, this 10 years old girl was playing with her cousin and he got poked in the eye, and now he complained of pain, redness, and tearing. After this complete history and eye exam, you find this in your fluorescein test. What you can find? He bought the fluorescein. You can see like uptake of that fluorescein and that's injury of the epithelial layer of the cornea. So this one, cornea abrasion, is very common presentation to the ER. Can happen by wrapping of the eye or foreign body, or there is any contact lens. What's the sign of this one? If he has intense pain, tearing, photophobia, there is any redness of conjunctiva. How to approach for this one, patient and management? Topical anesthesia as an anesthetic or anesthesia, like topical tetracycline as used for 24 hours was both safe and effective for pain management. You have to start patient an antibiotic ointment like erythromycin ointment or aflatoxin. Consider the psychoplegic agent, pain management. No need to patch for this one. Patching of that cornea abrasion is generally no longer recommended due to the lack of the high quality evidence and potential for increased this damage and lose of the depth perception, and this could be very discomfortable with this patching of that eye. When you need to ophthalmology consultation, possibility of the penetrating injury, large abrasion, involvement of the visual axis, and there is cause of the contact by contact lens for this patient, or there is any significant symptoms with this patient. Case number 3 is 16 years old boy gets in the fight at school and has a laceration on his forearm from the knife, and he has holding his eye in pain. When they examine his eye, you find, it's not superficial like the previous one. You find it's very deep in the layer of the sclera, also extend to the cornea. So crossing the limbus for this one, so is make more cutting to more than 2 or 3 layers of that sclera and cornea. So this is cornea or scleral laceration. It's very important to be more familiar with this one. If any patient present with the eye injury, usually sustained during that penetrating or blunt trauma. Usually sustained during that penetrating or blunt trauma, and chronic scleral laceration are repaired surgically by ophthalmology because this now the layers now very thin, so easy to be rupture, and there is a rupture group easy for this patient. Consider that ocular tissue prolapse through that wound, depending on the extent of that wound and intraocular pressure for this patient. What's the management in the emergency? Most important physical examination, is to be documented visual acuity, shield the eye and ophthalmology consultant, and psychoplegic may be used for relief the ciliary muscle spasm, can cause tissue which can cause the tissue prolapse, يعني decrease the chance of the tissue prolapse by psychological treatment. Provide tetanus vaccine prophylaxis, IV antibiotic, orbital CT scan may be useful to be suspected if there is any foreign body proceed through the cornea, pierce the cornea. The case number 4, this 5 years old was running and fell on his hit his face and on metal object and cut his eyelid. What to do and what you have to do for this patient, and what's the important you have to know about this case. You know, this is cutting that edge of that medial epicanthal, very close the caniculum. That's one canicular. That's canicular laceration. This will be very close to this lacrimal gland for this one, and also involve that edge of that lower lid. So it's very important, interesting to refer the patient to ophthalmology. So look for the global rupture. Consider damage to the nasolacrimal drainage system. You have to give tetanus and prophylaxis if not immunized. You have to consult ophthalmology in the patient with the laceration of the medial third of the lid. If the patient presents with the ptosis at the presentation, there is any tissue effulgence, there is a full thickness laceration through lid margin laceration. You have to repair this one and perform within the 12 and 24 hours from the presentation. This patient, 16 years old boy playing baseball. This is and got hit in his eye with the baseball after that hitter hit that ball. And before that, entering that room, you see the scan from that outside facility. See, there is a fracture in the inferior floor of that orbital bone, and there is bleeding for this one. There is distorted of that pupil, okay, and iris for this one, and there is some tearing for this one. And you see this subconjunctival hemorrhage more than 50%. So what do you think? Globe rupture mechanism of injury usually occur by the blunt penetrating and perforating object. Often globe rupture is very obvious on exam, but sometimes can be more subtle. Patient present with the symptoms pain, greatly decrease the vision and diplopia, a sign like teardrop pupil, prolapse, iris, hypemia, extensive subconjunctival hemorrhage, and chemosis. Examination focused visual acuity like continuous finger counting at that finger or light perception. Also, it's very important extraocular muscle examination for any interruption for this fracture of the floor of the orbital bone. This is the big pupil, okay, or can call this one teardrop, a regular pupil. Also, this Seattle test for this one, they can, when you put the fluorescent exam, there is a rupture group, will be seen like this. What's the management? Goal to avoid an increase of intraocular pressure, shield of the eye, nephral patch, pain relief, please, anti-emetic, sometimes maybe feeling nausea or vomiting. Keep patient bio, tetanus vaccine prophylaxis is very important. To prevent endophthalmic or endophthalmitis by systemic prophylaxis, prophylactic antibiotics should be given and cover that Staphylococcus aureus and Streptococcus and Pseudomonas or gram-negative bacilli is very important. 5 to 10% of this with penetrating at risk for endophthalmitis, which is lead to be vision loss. So immediate ophthalmology consultation for this patient. Case number 6, you ask him to look up what you are thinking, what is your suspicion for this patient. You see there is a fracture and the floor for this orbital bone. You think this is this interrupt of the muscle. So this is orbital blowout fracture. He present with pain, swelling, ecchymosis, epistaxis sometimes, orbital, sometimes emphysema. Maybe patient present with the hypoesthesia of the cheek, diplopia, cannot look up due to the edema and interruption of the inferior rectus muscle for this one. He is maybe present with the nausea, vomiting. He may be present with the bradycardia due to the reflex of oculocardiac reflex. What management for this patient should be seen for this by the ophthalmologist? Look for additional injury in 50%, maybe rupture global dysfunction. Instruct the patient not to be blow nose. Consider oral antibiotic 10 to 14 days. Consider surgery if this edema not resolved. Orbital fractures mechanism is secondary to high velocity sport injury or motor vehicle crash injury. The medial wall or the floor of the orbit is the commonest presentation of that fracture. Children usually less than 7 years old fracture in the roof of that orbital bone. Lateral wall is very rare or with the sigmoid fracture. Indication for surgical intervention in the orbital blowout fracture, evidence of the muscle interruption, early enophthalmos, large fracture, presence of the strabismus the diplopia for this one, presence of the pain or the eye movement. Patient in case number 7, he's a 3 years old African American girl, came with the eye pain after getting hit in the eye with the toy truck. What's that clue of this case diagnosis? This patient present with the some in the anterior chamber, there is some bleeding. And you think about this is anterior chamber, there is bleeding and hypemia. Blood in the anterior chamber of patient present there is rupture of the ciliary blood vessels. That's mechanism of the injury usually due secondary to blunt or projectile or penetrating trauma. Usually occur in the 70% of the time of the pediatric population. The majority of patients of hypemia have less than 50% of that anterior chamber blood. What's the sign or the symptoms? Usually present with the pain and decreased vision and injected conjunctiva or irregular pupil. It's very important to grading of that patient present with hypemia is starting for that grade 1 less than a third of the anterior chamber. Grade 2 is from third to the half of that anterior chamber, and also grade 3 is more than half, and for grade 4 complete of anterior chamber there is blood. This depends on this grade. You can think about prognosis and visual acuity in the future. Complication for this one, secondary of that hemorrhage or rebleeding is very important to think about it. 80% of patients with the hypemia will be recover their visual acuity, but with 64 of patients with secondary hemorrhage will most likely due to that lysis of that and traction of that clot and fibrin aggregate for this one. High risk for this rebleeding the fourth and the 7th day after that injury. Occur almost 25 of the patient with the hypemia. Higher grade of the hypemia increase of the risk of rebleeding, increased risk of the younger age, up to 30% of patients younger than 6 years old with the secondary hemorrhage. Okay, 2 to 5% of blue eye individual and 25 with the African American people. Decrease that's recovery of the visual acuity of 20 over 50 of that about 6 to 65. There is rebleeding. Coronary blood staining anterior or posterior synechia for this patient or adhesion. Okay.
ستحتاج إلى مدح طفلها.
Also amblyopia elevated of intraocular pressure, inflammatory change leading to the glaucoma and optic nerve damage for this patient. How to manage for this patient present with hypemia is elevate the head on the bed 30 to 40 degree and give both in the eye shield, pain control to avoid any anti-platelet effect of certain non-steroidal anti-inflammatory drugs. Limit their activity for 1 week. Sometimes they need to hospitalize the patient to admission. Patient with low-grade hypemia should be treated as outpatient. Open global injury, you have to be admitted. Risk rebleeding and sickle cell trait disease or bleeding disorder. Large hypemia covering more than 50% of the anterior chamber. Intraocular pressures, the time of the presentation is around more than 30. So you have to be considered social concern of that compliance of that abuse is very important. Typical psychoplegic drug can be used for this patient and also reduce the ciliary muscle spasm and dilate that iris to decrease the pain. Can be used the topical myotic drug for this one to lowering of the intraocular pressure. Topical or systemic amicar or can be sometimes be used. Tranexamic acid is very helpful to anti-fibrinolytic agent to preventing of the normal occurring of that clot lysis to allow the blood vessel time to be repaired. Decrease that associated iritis and development of the synechia for this patient. Consider the checking of that complete blood cells count and coagulation study and hemoglobin is for that patient. Case number 8, that patient present with this bleeding underneath of that conjunctiva, subconjunctival hemorrhage. Okay, when there is tiny blood vessels breaking just underneath of that conjunctival, subconjunctival hemorrhage often occur without any injury to your eye. It may be that result of the strong sneezing or coughing. Despite this bloody appearance, subconjunctival should be cause no change in your vision, no discharge from your eye, and no pain. Your only discomfort may be scratching feeling on that surface of that your eye. You don't need to any specific treatment for this subconjunctival hemorrhage. It will be disappear within 10 to 14 days. This other case presented what's wrong with this patient in this picture. This is retrobulbar hemorrhage secondary to trauma. Mechanism of injury usually after the blunt or penetrating injury. Sign of acute proptosis or subconjunctival hemorrhage, decrease the vision, pain, limitation of the ocular movement, maybe lead to the lose of the vision because that's central retinal vessels occlusion from that hemorrhage. What you have to do for this immediate ophthalmology consultation, have to be intervention must be performed within 2 hours from the presentation. IV mannitol or decrease intraocular pressure, IV steroids, lateral craniotomy sometimes if you have good experience for experienced persons. The number 10 case, this present like this after exposure for chemical. This is it's very important to know for chemical pain, and if they present to the ER, no history, no physical examination you have to do for this patient. You have to start with this presentation. Copious irrigation is the key important management for that patient. 1 to 2 liters of the saline with the if you didn't have normal saline, you can give ringa lactate for this patient. First, the lid with to be ensured for irrigation, apply topical anesthesia for this patient. Immediately begin with the irrigation for 30 minutes until that pH for this normalized from the 7.3 to 7.7. Time for same for this chemical pain is to the eye is very important, and acid pain because that's coagulation, necrosis, and the nature of that surface protein maybe usually don't penetrate that eye. Battery fluid and chemistry lab solutions that can be exposed for eye for some pain or chemical. Alkali pain are more harmful than acid pain. Alkali pain can cause rapid penetration through that cornea and anterior chamber, combining with the cell membrane lipid. Alkali pain can cause corneal liquefaction and necrosis. Lye, cement, cleaner, drain cleaner, fertilizer, and fire crackers that produce the alkaline pain, and that's because these are contain sodium hydroxide. Management after 30 minutes of that copious irrigation, pH should be normalized within 7.3 to 7.7. It is important to remove any particles or matters that's immediately before irrigation, since that alkaline particles can matter maybe cause more harm of these dissolved in the solution. So remove the any particles of this from that eye and start irrigation for this patient. Visual acuity assessment is very important. Fluorescein to be checked for this any epithelial defect. The use of the topical anesthesia and fluorescein can be affect that pH reading. So sometimes you can postpone this one later on after irrigation for this patient. Ophthalmology consultation is very important or should be seen by the ophthalmology, may require corneal or limbal transplantation. Psychological agents sometimes very helpful. Topical and antibiotic is very important. Don't send home with the topical anesthesia. This is one of this technique can be utilized. This one, this Morgan lens. This is very important to be more familiar for this one and to be available in your department. Should be avoided if there is any foreign body material present in the or concern of the open global injury. Prior to the insertion of Morgan lens for irrigation, use that topical anesthesia. Okay, for the eye, and consider giving of oral analgesia to minimize the discomfort for this Morgan lens. Minimum 2 liters or 30 minutes for irrigation are recommended in the mild cases. Sometimes we need go for 10 liter or within 2 to 4 hours, or in severe cases. Okay, you will insert this organ below the upper lid, and also you can between upper and lower lid to fix it. And you can start connect with the drip. Will be continue depend what you calibrate this one. If you keep 2 liter for 30 minutes to finish 2 liter within 10 minutes, or 10 liter within 2 to 4 hours. pH should be checked again 30 minutes after a normal pH is reached. You have to be checked for this patient. It's rule 2 classification of systemic of ocular pain is this one good, and this prognosis if this cornea epithelial damage, the prognosis is good. Just corneal hazes and the iris details visible. If it's good, it's grade 1 and grade 2, 3, and 4. Depend on the conjunctiva limbus, no limbal ischemia, less than third of the limbal ischemia, and third and half of the limbal ischemia for this patient. If it's more than half limbal ischemia, this one is poor prognosis for this patient, may need to transplant. Thank you.
Thank you very much, Dr. Hamad, for this comprehensive talk of eye injuries.
Some ask about the psychologic agent. This psychologic, this is used some drops, drugs. This will make a relaxant of that ciliary muscle of that iris to decrease the spasm of this one. Dr. Saleh, are you ready?
Dr. Hamad, just give me one second. Just I'm preparing slides, and please close your share screen, please.
Okay. Till Dr. Saleh al-Shehri is ready, we can answer some questions from the audience for the last lectures. Somebody here was asking any specific agent recommended for RSI in trauma. Okay. This is from Dr. Amuna, I think. Yes, usually as a standard for trauma patient, we prefer to use as a paralytic agent succinylcholine, because the half-life is very short. So if you fail to intubate, the patient will regain his consciousness right away. We don't like to use this like procronium, vicronium, because this will take maybe 1 hour, like a half or to 2 hours, unless you are sure about your skills of intubation. Most of the ER physicians, they are using succinylcholine. This is for intubation as a paralytic agent. And for sedation, you can use like something that can maintain the blood pressure, like etomidate, or sometimes we use a small dose of midazolam, or even ketamine. All right. Some people, they said ketamine, it can cause intracranial pressure increase or intraorbital pressure. But if you use like a small doses, it will be okay. A question here from Turkey. Does the ER doctor bear responsibility if the foreign body move and cause more obstruction and the condition worsen? Well, as a physician, the risk of mistakes for doing any procedure is there, okay? But if there is like what we call it, like if you try your best and you fail, I don't think there will be any consequences. But still, if you feel you are not confident and you have a doubt, it's better to call your senior or to call somebody to help. Because now in our system, there is sue cases, and if the family complain, and there is so many, I know some of our colleagues, they went to the court for some of these mistakes. But if the doctor, he is doing his best, the risk of that's why they are asking the families, even the lady before she goes and for delivery, in case she needs cesarean, they ask her to sign, okay, the consent. If there is any complication or anything, the physician will not be responsible, and most of them they signed, otherwise they won't accept them in the hospital. Okay, do your best, and we are human. The risk of mistake is there, but if you are careful and you try your best and you made a mistake, I don't think there will be a consequences. Dr. Saleh, once you are ready, please let me know.
بسم الله الرحمن الرحيم. Ready إن شاء الله.
توكل على الله. يعطيك العافية.
طيب بسم الله الرحمن الرحيم. والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد. Now I'm going to talk about the maxillofacial trauma. This is part 2. Yesterday we spoke about the part 1. Does anyone can see my slide? Okay. And somebody said you cannot see it. Okay, good. So, Bismillah ar-Rahman ar-Rahim. We're going to review the evaluation of facial trauma here, describe the different anatomical features, pediatric facial trauma, and identify various pediatric face of the injuries there. Pediatric maxillofacial trauma is relatively uncommon compared to the adult, but the incidence has been increased with age, especially when a child walk after first year of life. Male is more than female, 3 to 1, and cause is vary with age. Mainly non-accidental trauma, fall from height, motor vehicle crash, and fight, sporting injury, and gunshot. We should be, why is facial important injury trauma here? Because, it's enriched of anatomically things, a lot of arteries, vessels, nerves. We have also soft tissues there. It's cosmetic also for the human being there. It's all the cosmetic things there from the all sides there. This is the importance of the vein there, which is including in the face from the ophthalmic, trigeminal, maxillary nerve, mandible, and orotemporal nerve. And one of the submental nerve here, which is for the sensation of the jaw. Sometimes you need to be careful when you're doing sutures or some procedure at the jaw bone there. What about the evaluation of facial trauma? It's primary or survey. Then we'll go to the secondary survey. The importance of the primary survey that we will need to detect all the life-threatening things there, from airway, breathing, circulations, disability, and expose, and determine the response of the patient, and if possible, determine what's the glass coma scale. Secondary survey that from head to toe examinations, even the patient have isolated trauma injury to the face, but also we need to rule out the red flags there. Then we need to go to the history, inspection, observations, and palpation, and doing the special exam for all the body there. Pediatric trauma, maxillofacial trauma, initially management is to go with to detect any airway compromise. The one thing that we are worrying about it, the bleeding in the mouth and the nose there, we need to clear it. Loss of skeletal support and hypotonic because of the low GCS. Any swelling there in the face, either to be due to the allergic or because of the trauma there, or لا قدر الله tracheal leaks there because of the emphysema. Be alert also, of course, we need to be alert to the unconscious patient or any glaucoma scale less than 11 there. For the airway protection there, jaw thrust and maintaining the C-spine. And as we mentioned in the previous lecture, we need 2 persons to maintaining the cervical spine immobilized. If the airway not maintainable, we can directly use orotracheal intubations and avoid nasotracheal intubations unless we clear the patients from any basal skull fractures or severe head injury. Think about surgical airway. Consider other injuries for spines, head injury till be ruled out, clinical and radiological, often more comfortable setting because of the blood and secretions. Inspections here, careful to the swelling, laceration, bruising, movement, careful to the ductal area and the medial 1/3 of the eyelids there, upper eyelid, because of the lacrimal duct there. Sometimes we give great cautions to that area, and maybe we need to call the specialist for this. The mouth, upper mouth, also because of the facial nerve and parotid gland. We need to palpate all. We need the palpation all the face. Look for any deformity, for any crypts, which is meaning already some broken to the sinus there. What about the physical exam here? Look to the pupils, equality both. Is it round? Is there any evidence of tear drops there? Look for hyphemia in both eyes, proptosis, retracted lids, extraocular movement. We need to test it both. If alert, do you see it double or one objective accurately? Document also the acuity of the vision. Be careful about the immediate bruise, that means direct trauma to that site. So carefully examine that area. Also look to the hemotympanum that associated with basilar skull fractures. Vital signs may not be immediate there. Tympanic membrane rupture also. There's some study that most of the healthcare, they didn't examine well the ears there. Even there's a lot of information can be found there. What about facial anatomy in kids? Careful about the accelerate rate of healing, faster craniofacial growth. So once the child being healing, deformity also can be increased there. Yes, they have fast healing and growth, but at the same time, they can have faster deformity. So we need careful attentions and fast treated patient and good follow-up later on. Also careful about the dental developmental. Facial fracture here is 4.6% of pediatric trauma. Significant morbidity because they have large face. 55% of the facial fracture cases have severe concomitant injury because, the facial fractures meaning need high power of trauma to break the bone in the face. Mechanism of injury, maybe MVA, 55%, assault, 14%, fall from height, especially from 2 meters or double height, 8.6%, and also child insult or non-accidental trauma. Skull fracture here, it's associated with the intracranial injury trauma, falls from most of the common mechanism less than 2 years, sport injury in the adolescents, and also the NVA contribute to the high percentage of skull fracture there. Pediatric skull and fracture anatomy. Pediatric versus adult, the pediatric, they have thinner bones there, and they have large head to torso ratio. Retruded positions of the face is relatively to the skull. Fractures pattern here, it can be linear, comminuted, or depressed, or open, and growing types. This type of fractures and presentation, this is the breast fracture here, but no bleeding there. And also we have some linear fractures comminuted there. Depend on the clinical presentation. If it's isolated skull fracture, will not be worried, and patient can be discharged after conducted neurosurgery and to clear him, and patient can sleep at home with instruction. If there is some change in the examinations or red flag there, no need to be referred to neurosurgery and admitted to the intensive care unit. You know, I think most of you are you aware about the indication for CT in pediatric? And I think most of you are aware about this picture. It's very famous everywhere. What about children younger than 2 years? Because of the younger 2 years, the Glasgow scale, if it's less than 15, palpable skull fractures, altered mental status, you need this high risk and high indication for CT. If scalp hematoma the patient have passed away like for more than 5 seconds, and he's not acting normally according to the parent's history, and there is some severe mechanism. I will mention more than double height all the time. This will be considered as severe mechanism. If there is any question about that, either to have observed him in the emergency or just send him for CT and rule out serious event. I think there. What about above 2 years? Same, Glasgow scale, less than 15 years. But here we have less than 15 Glasgow scale, sorry. Plus, if you have signs of basilar skull fractures or any altered mental status there, we may indicate for CT here. If the patient only having vomiting, if having loss of consciousness, there is no time for this, severe headache, severe mechanism of injury, either to observe him or go direct to send him for CT. Mandible and mid-face fracture, and this is more common in the adult. Unfortunately, kids, if they present with severe facial trauma, mortality here is very, very high. So most of the study is coming from adult side, not from pediatric. And this one need to be reconstructions by the OMF and plastic surgeon. They may need too many operations to fix it and reconstruct it from inside the mouth, from outside the mouth, from everywhere to try to make it as close to the normal. Most of them, they will not come to the normal face, but with our recent OMF specialized and plastic, they will try to correct it as much as they can. The commonest trauma coming to the emergency, one of the commonest trauma to the face is nasal fracture. Most common facial fracture here. Just one question. With I don't know about your practice. I'm just asking this question for everyone. يعني هذا السؤال يعني عام. With nasal fractures and nasal swelling, is it routinely to do X-ray for patient coming to the emergency? يعني واحد جاك الطوارئ وعنده إصابة في الأنف والأهل قلقانين ونبغى أشعة. Is it routinely to do X-ray just to rule out things there? اغلبكم قالوا نو. يا ليت عندي اقدر اسوي الفوت، ماني عارف كيف اسوي الفوت هنا، لكن يا ليت نعرف الإجابة اللي أغلبكم بيسويها. يمكن واحد قال يس، 2 3 4، والباقيين ذكروا نو. تقريبا إجابات متساوية تقريبا بين يس ونو. حقيقة إنه لما نرجع إحنا للإيفيدنس بتذكر إنه no need to do X-ray routine X-ray. It's useless. ليش؟ لأنه أغلب الكتس ذي النازل حقتهم is mainly cartilage أكثر منها تكون بون فيها. في الغالب إنه ما بتستفيد منها كثير unless there's some deformity there. The only indication is to do CT, and always we try to avoid the high radiation there. فإيش الحاجة اللي بتقلقني أكثر شيء في النيزل تروما هير؟ أهم شيء عند السبتم كمبوز also the patient maybe apparently is not coming with a swelling or evidence of trauma تكون واضحة. أحيانا يكون بأكتف bleeding. إحنا عارفين، كلنا عارفين موضوع الليتلز اريا أو كسل باخس الألماني اللي مسميها كسل باخس plexus here which is direct anastomosis سبحان الله بين الارتريز وبين الفين في المنطقة هذه which is one of the two sit في جسم الإنسان having this plexus. والمشكلة هذه الاريا it can dry وit can break through في كثير من الأحيان مع dry weather أو زي كذا كان broken the wall ويصير منها bleeding. لكن أحيانا أي direct trauma here we will have extensive bleeding from this area, from little area. كثير من السنترز they consider to do X-ray if there is some bleeding or CT scan or something. Actually with examination you may find the bleeding is coming from this area and usually coming from one side, and the commonest side right or left in the nose. أكثر شيء تيجي من الرايت more than the left side في little area. Just consider this one, the bleeding can be because of this side, because of the direct trauma, and how to need to stop it. Most important في النازل exam when we look to that, عندنا مشكلة مع the physical, we need to inspect both anasai here and to palpate for any evidence of mobility here or crypts in the nose, and look for the septal here. And what can we see here? This is what we call it septal hematoma. If we leave the septal hematoma without treatment or not detected during the exam, what can happen to the patient? Is it going to be okay? Necrosis where? Septal necrosis. فنيجي هنا الموضوع evidence imaging, not necessarily, usually diagnosis is clinically here. طيب, palpable of the mid face is a part of examination of nasal and head trauma and the face trauma. Yes, saddle deformity, you are right. Intraoral palpation of the arch is a part of the mid face examination. Check for the movement of the hard palate and soft palate there. النوز ذكرناها أمس CSF rhinorrhea. If there is blood, look to the double ring, which is meaning there is presence of CSF and blood here. So there's CSF leak here and evidence of skull basal fracture here. Look for septal hematoma, important. So the follow-up is important with most of the nasal trauma here, especially if there is no obvious deformity. Within 1 week, less than 1 week with the ENT. If there is deformity, we need more urgent, and we need to contact the ENT, and the ENT they will give them follow-up. If there is septal hematoma, this is an emergency, and we need to consult the ENT. So what's this picture? This is saddle nose deformity. What about soft tissue injury here? 48% it's outdoor versus 45% it happened inside the door, inside the house, and 6% in the school. The cause of injury it is struck or bumping something in 32.5%, slide down 31.5%. الكومنس برضه كمان بيجون الامرجنسي انه صقع في صدم في الكنبه ولا صقع في الارض ولا في الطاوله. So the furnitures stuck to the furnitures at home 9% and the chairs for 9%. History is important here about the traumatic force, associated symptoms of head injury, about the age of the wound, because if it's more than 8 hours or 12 hours, cosmetic here will be less for patient when we repair it, and sometimes we will keep it open, especially if it's already infected. Careful about what type of trauma that can cause to the wound contamination and wound infection that need to be clean the wound very well, and potentially present of any foreign body there. We can provide local anesthesia to examine the wound, and we can examine it well. Try to avoid giving a lot of local anesthesia, especially like this child, in the face, in the mouth, in the nose, whatever, because you will not align the edge well. So try to use a spray or maybe local from outside anesthesia. This will maybe sometimes enough to examine it, the patient. But don't give a lot of local anesthesia here. Sometimes some of the wound that with uncooperative child, we may go to the procedure sedation. Keep the child sleep well and safely, and then we'll go ahead to examine the wound and repair it. We'll go to the wound, need to describe it in the file of the patient. Where is the locations? What is the length of the wound? What is the depth also? Because either we need 2 layers or 1 layer stitch. How about the shape? This is one of the easiest wound here that was in the child. Is it how the shape and any skin loose? And overall, the answer that we needed is the emergency can do repair for this one, or he need to call a specialist, or need to refer patient to the trauma center to complete their service there. How about soft tissue injury repair here? We need to clean the wound well. Basic closure technique here to deep layer absorbable suture. All the deep layers, we need to use absorbable sutures because we cannot open the wound again. Use either Fecrel or monocrel. The superficial layer, أعتقد most of us they are using absorbable. You can use non-absorbable, but to avoid the patient coming back to the emergency to remove the suture, we can use the absorbable one, Fecrel or monocrel. Sometimes we can use non-absorbable like Prolene if the absorbable is not available. One of the advice that try to use the fast absorbable or short acting, try to avoid it in the face, especially the small size like size 6. That one, the ultra, can be absorbed fast and wound sometimes it's open again. About the tongue injury, are you going to repair the lung wound? This is my question. Are you going to repair this one? This tongue wound here? حد معنا? So tongue injury most of the time. Why? Okay. هو يعني اختلفت الآراء فيها. قالوا إنه deep wound even not through and through, it need to be repaired to avoid the infection, especially في the mid of the tongue. لكن زي هذا superficial يعني احنا بنشوفه before and after this, after 5 days or 1 week by the way, without repair here. فالموضوع اختلف هنا، بس إنه في كل الحالات إنه تعطيه soft diet Usually saliva will go to work like antibiotic for any infection there. بس شوف الصورة هذه to go by itself, it heal by itself. This after 1 week. لأنه الtongue highly vascularized والhealing حقتها very very fast. لكن deep wound she may need a repair. زي ما قلنا اختلفت الآراء فيها deep wound because of the risk of infection. Also the wound had been continued to bleed because it need to be sutured and to fix that bleeding. All the cut wound that's through and through need to be repaired. Also risk of infections and alignment of the tongue. What about lip laceration? Can we do it in emergency by the ER physicians or no? Lip wound indicating here for suture if the lip laceration cross the vermiculum here, like what you see it here, that need to be cosmetic repair. طبعا alignment, if we keep it open, الwound ما راح يصير alignment واللبس ما راح تكون well aligned, حتكون bad shape later on وممكن تكون short than the down. The best things, take it from the middle and give one stitch just up at the level of the lips, upper lip there, upper border there. Just this is the center. This is the center. And after that, you can go through both sides here. But the first important stitch, that's in the middle, at the side of the wound, just above the border of the upper border of the upper lip, or down border for the lower lip. Also, all the lip cut wound that's coming through and through need to be repaired. في شيء مهم برضو كمان في موضوع الانستيزيا، لوكال انستيزيا في اللبس. Try not to giving much anesthesia, lidocaine there, لأنه راح to damage the cosmetic and the approximations. Sometimes only you need to give spray or by cotton put the anesthesia to be absorbed there and to anesthetitis there. And sometimes even we need to giving procedure sedation. But will not give much there because it will inflate the edge and you cannot difficult to approximate it. طيب. Antibiotic for soft tissue. Are you going to routinely giving antibiotic for soft tissue there? Are you going to routinely giving antibiotic? طيب. Most no need for empiric antibiotic. It's local cleaning will be enough there. Yes, most of you said no. But sometimes we need to use antibiotic to decrease the risk of wound infection, like in animal or human bite, intraoral lacerations, wound that extend to the cartilage, and excessive wound contamination, or in patient of immunodeficiency. مجرد سؤال بس, which is the most dirty bite, animal bite or human bite? يا ساتر, أنا أسحب السؤال. الجميع أجمع على أنه human, صح؟ طيب.
Human and I think wife, like.
The wolf. Face wound care. Don't wash the wound for 24 to 48 hours. This advice always to the parents after repairing the wound, just to allow some healing for the wound and we will not damage the alignment there. Wash wound as needed with a mild soap ويكون خفيف في أول 5 أيام. Apply antibiotic ointment for 5 to 7 days, and avoid the sun or use high sun protection cream. هم ذكروا above 75 plus or 50 plus. Try to avoid to give it to the child. This will interfere with the healing of the wound. طيب dog bites because يعني unfortunately يعني سبحان الله احنا قمنا نشوفها الفترة القليلة الماضية، صرنا نشوف many animal bites especially from dog bites. في أمريكا في عندهم 4.5 million dog bites annually in the United States. 10% on the face. Mainly preschool children more likely to sustain bite to their head and face. وفي death يمكن اللي شفناها قبل كم شهر، الطفل اللي كان معهم كلب في البيت مسالم وفجأة هجم على الولد بدون ريزون، كان الولد يحبي عمره 8 شهور. The child he died I think after 5 days or 4 days في ال ICU mainly because of bleeding and infection there. ففي United States في عندك 20 deaths per year associated with dog bite annually United States. Unfortunately most of the dog is from the house. هذه البنت كانت مع الدق وفجأة خرم لها وجهها هنا، وهذه يعني هم هنا بيمثلوا هنا تقريبا بس تقريبا almost تبدأ البايت زي كذا، إنه فجأة صدر لي الدق يبدأ يهجم على الإنسان. طيب إيش السيتويشن اللي بيحصل فيها إن الدق يبدأ يهجم على الإنسان فيها؟ either to playing with or near dog، الدوغ يمكن ما أعرفه فهجم عليه هذه 28%. passing dog اللي هم في الستريت dog. cuddling the dog also. feeding the dog during the feeding بيهجم عليه. passing the dog from cycling. disturbance of dog whilst eating or sleeping. surprising of the dog غريبة هي بس only 2%، وأنا توقعت إنها تكون number 1 هذه surprising the dog. following the duck's tail جماعتنا مو مقصرين في هذه بس الحمد لله إنها قليلة 2%. interfering during dog fight and unknown reason. طيب ايش الكومنست باثولوجي حتى نعرف كيف what antibiotic to be start. الدوغ عندك ساتوفيج كانيموروسس، هذه the commonest organism. الكات دائما نخاف موضوع الباستريلا والباتورينيلا. الريت الستريبتو باسيلس. يعني هذه هي الكومونست اللي موجودة بيننا، هذه اللي على الإنسان فيها، ومصطفت الحمد لله responding well للأوجمنتين والأموكسيسيلين. طيب الهيومن بايت سبحان الله العظيم الله جمعها عندهم كلهم سبحان الله. قاعدين نشوف الكامبايلوباكتر، قاعدين نشوف الهيموفيلس، الستريبت بأنواعها، نشوف الستاف، نشوف الستريبت، يعني ما خلينا شيء. هذه all common bacteria in the human bite. Initial management of dog bite here to do irrigation الwound، وطبعا هذا نفس الشيء ينطبق حتى على الكات wound وعلى على الهيومن بايت. irrigation the wound carefully. What about diagnostic image? Here we sometimes need it if missing tooth from the dog, or if you think about any foreigner inside ويحس بشيء في inside we may do X-ray for that. نحتاج نسوي obtain wound culture if the evaluation happened after 8 hours. So the bacteria already grow there and we need to isolate it by the culture to determine either to continue or change the antibiotic later on. Early primary closure after good irrigations of the wound, a strong irrigation of the wound can happen immediately if the patient present after the bite immediately. But if the patient present late after 8 or 12 hours or any evidence of infected wound, here we cannot close it. We need to keep it open for secondary healing later on and follow up with plastic. About the prophylaxis here, determine the need for rabies and tetanus and prescribe antibiotic if there's wound to the face, immunocompromised or asplenic patient, moderate to severe puncture wound, injury to the bone, joint, and tendon for their antibiotic. The first choice is amoxicillin and penicillin. Here, this is the adult dose, but we can go with the 90 milligrams per kg per day for kids. The alternative, if there's some showing allergic, either to metronidazole or doxycycline. Vancomycin, there is questions about that. Can be used, and sometimes we still doxycycline. Second choice is better than Clinda. Rabies vaccine. Maybe the dog is not the main carrier for the rabies. Unless you see there is some disturbed behavior with or irritability or agitated the dog there. So this is strong indication for rabies. But the main carrier for rabies is bat here, then fox and cat. Even the cat need to be careful about that. And unfortunately, till now there's no treatment for rabies. The only is either to give the vaccine or immunoglobulins for that. But if the patient already having rabies infected, unfortunately, nothing can be done for the patient. Some point here later, isolated at the end of my lecture here, isolated skull fracture can be discharged home, but with close observations and strict written precaution. Nasal fracture here are clinical diagnosis. Most of the time, no need for imaging. Don't forget to assess the nasal, to assess the nasal cavity. Children always should be supervised when interacting with animal. Thank you so much, and I'm happy to receive any question.
Thank you, Dr. Saleh. Any question for Dr. Saleh? دكتور صالح، اسمعني دكتور صالح.
أيوة, yes.
في question يقول when you have to call the plastic surgery for lip laceration or any cut wound in the face. طبعا
ماشي.
ها تفضل.
هذه personal expert. If some center they like to repair the wound by the emergency physicians there. حتى يمكن many center حتى في North America to be done by the emergency physicians. But any deep wound passing the fat and to the muscles, هذا definitely need to be go to the plastic. Lips trauma or lacerations can be done by the emergency physicians, but extensive through and through fully separated lips, I think better to refer it to specialized because this is cosmetic, especially if the girl.
Usually
عموما more than 1 centimeters depth or length, they need to be go to the plastic. Vital area like the parotid area, nerve, lacrimal duct also injury there. فيها you need to be go there.
So any complicated case is better to be managed by plastic.
Yes, and infected. If you think there's an infected case.
Usually the cheek is not easy to be managed in the emergency. So because that's complication. That cheek laceration can sometimes difficult to be managed or to
large, yes, لأنها mobilized area. Whatever you will do, it will be open. Sometimes you need to fix the hip movement and ask the child to be in the soft diet to not allow mobilizing of the skin, especially if it's extensive, need 2 layers, more than 1 centimeter length of the lacerations. يعني إذا كان فيها bone exposures affecting the vein, فيها numbness, it's better to refer to the plastic surgeon.
There is other question. He mentioned what is the maximum dose for anti-rabies?
يمكن قصده الإيميونوجلوبولين.
Yeah,
إنه
immunoglobulin.
بس 1 dose هي نفس الأمبيولا.
Yeah.
لكن إذا كان قصده الإيميونوجلوبولينز، الأمبيولا عادة يكون فيها 2 ml في الأمبيولا الواحدة.
Usually, not all cases you have to give immunoglobulin. For this patient, is not non-immunized to this patient or need to go for to give immunoglobulin. Usually,
You can't use immunoglobulins for rabies. Very rare. ساعات من 1 to 2 ml per kg.
you ask about what's about animal scratch will be treated. It is a bite.
والله most of the literature that need only local treatment, local cleaning and treatment, and local antibiotic. No need for systemic antibiotic for scratch.
So I think no more question for your talk, and I think we'll go for break. We'll back at 1 o'clock sharply. Thank you, Doctor.
توكلنا على الله. جزاكم الله خير جميعا. بسم الله.
Now we'll start the third session for our activity for today. Today I will cover 2 parts, very important part in the pediatric trauma, that's fracture. So we'll be divide this one to upper limb fracture and lower limb fracture. So we'll go through it and how what's the good management, what's the good plan for that, how to deal with that patient. As you know, this is pediatric trauma is very common to see in the emergency department. So you have to be more familiar with the type of fracture, which patient you need to go for orthopedic and discuss with the orthopedic and consult the orthopedic, or which patient it can be managed by pediatric emergency. First, you have to be familiar how is that pediatric development bone anatomy, and you have to go through that anatomy and what's the part of that bone. This is epiphysis, and this is physial or physis growth, and metaphysis and diaphysis. Okay, so need to talk about the blood supply is very important. Blood supply to be more familiar with how to be vascularity of that part of that bone. Usually that supply from the epiphysis and metaphysis artery for this patient, and in the infancy age or in infant age, usually transphysial blood supply for that bone. So when you speak about the physical growth, usually is content of the multiple zone, rapidly dividing and not yet calcified. طيب. So the most thicker part in the bone in the pediatric age is pre-osteum. So bone is that's more elastic in the pediatric age, so allow for unique fracture type for that pediatric age. So common to see the torus fracture or buccal fracture and grain stick and bone in the pediatric. You cannot see this one in the adult. Also the effulgence, because that muscle and tendon is more stronger than that's bone, so easy to see that's effulgence and by the tendon rupture. Salter-Harris type classification is very important. You have to be more familiar how to classify this patient with which Salter-Harris type growth, the Salter-Harris type of fracture. So type 1, usually you cannot see anything in the X-ray. Patient feeling pain, you cannot see any linear fracture or anything. Sometimes most of cases present with the Salter-Harris type 1. Salter-Harris type 2 is the proximal bone for the usually in the metaphysis area. So is no anything you can see in the epiphysis of this one. But in the Salter-Harris 3, you will see this one, the distal part. Okay, the proximal is intact. But when you complete involve that proximal and distal will be labeled this one in the fourth. If there is any crush or compress for that epiphysis or growth plate, this you can label as type 5. So it's very important if he's 5 to discuss with the consultant, the orthopedic, to raise the pressure, do not interfere with that growth plate and affect the growth of the bone. Now we'll go through the upper limb fracture. It's very important to familiar when you make report or consult the orthopedic. You have to mention if this patient is displaced fracture or angulated fracture or shortening of the bone. It's very important when you describe or make good interpretation for that X-ray and to consult the orthopedic. Also, this is very important for assessment of the nerve supply for that upper limb. Nerve supply, as you know, that nerve supply for the inner side from that little finger and half of the fourth finger or the ring from the anterior and posterior from dorsal and palmar surface will be supplied by the ulnar nerve. Palmar surface, all the rest of that, all the other finger will be supplied by median nerve. And also supply also in the median in the dorsal surface for the distal part of the forefinger, especially just only half of that distal part of the ring finger. The rest of that dorsal surface supplied by the radial nerve. Also, you need to go for motor assessment for this animation with the fracture to see if this median nerve is intact by ask the patient to make good flexion, if she see this median nerve is intact or not. If the patient will make good assessment for radial, just ask the patient to make a good extension of the wrist and the carpal phalanx joint also we make good extension. If you want to assess the ulnar nerve, you will be nerve will be supplied motor for the small muscle between the fingers will be have to make good abduction and adduction for the fingers. If you make good assessment for anterior interosseous nerve, you have to ask the patient to make good thumb flexion at and interphalanx joint of the flexion of the index finger at the distal phalanx joint. So just ask him to make like this to assure that patient is intact for anterior and interosseous nerve. Clavicle fracture is most commonly fractured bone during the delivery. Around 10 to 15 of the all pediatric fracture, that's around the fourth fracture bone in the older children. More than 90% of that fracture of the clavicle is in the middle of the third. And you can manage by a sling or for comfort for 3 weeks, and give good pain management, and excellent remodeling will happen for this patient. But you have to warn that parents who this will be bump or lump will be developed later on. Don't be aware, don't be worried about this patient. Sometimes it can be developed some scar for this one. What you need for this, just only follow up with the family medicine doctor or orthopedic after 6 or to 8 weeks to be sure everything is good with good healing. Maybe sometime take a long time to see radiographic healing with that fracture. There is a study showing if you make a figure 8 bandage, that's all traditional way of management of that clavicle fracture, or you can just simple sling. This the study done by the Anderson. This random control trial for the 79 patient. He did figure 8 bandage and simple sling. Simple sling caused less discomfort and perhaps fewer complication than the figure of the 8, and that's functional and cosmetic result of the two methods of the treatment is identical, no any, and good alignment for this one, so no difference between two approach. When you talk about the proximal distal clavicle fracture, is not common as the middle, but you have to think about it. If this proximal clavicle fracture is around less than 2%, but usually if he's displaced posterior, may get that's tracheoesophageal compression, and maybe need to go for CT scan to consult orthopedic and to release that pressure on the infrastructure for this displacement by the proximal clavicle fracture. Usually is Salter-Harris 1 or 2. About distal fracture clavicle, sometimes you may confuse with that patient present with the acromoclavicular joint separation. Need to make good orthopedic follow-up and grossly if the patient grossly is an unstable patient, they have to consult the orthopedic. What about shoulder dislocations? They are uncommon for the pediatric, but you think about dislocation. Usually anterior dislocation are much more common in if you are speaking about dislocation for shoulder for pediatric compared to that with the adults. This is the posterior dislocation. Second examination, you lost the rounded contour of with the slight abduction and external rotation for that shoulder, for that upper limb. And there is the humeral head may be palpable anterior to the glenoid fossa. When you do AB and X-ray for that shoulder, our trans-axillary view will be provide adequate and you can provide good view for this one. You can see that's the head of the humerus will be displaced a little bit away from the glenoid fossa. So sometimes you can use the ultrasound to help you to differentiate it if it's anterior dislocation or posterior dislocation for the shoulder. You can give adequate analgesia and relaxation before a reduction with either traction or counter traction. You can do scapular manipulation or external rotation for technique can be very helpful to retain back that reduction back to the normal. Immobilize the joint with that reduction with 3 to 6 weeks. Then we can do rehabilitation therapy. Axillary nerve, one of that complication can happen for with the shoulder dislocation. So we need to assess the sensation over the deltoid muscle before and after the reduction for this patient. What about the proximal humerus? Usually, if you want to speak about age for this patient, with that proximal humerus fracture is from age of 5 to 11 years. You can present with the Salter-Harris type 1 fracture, grain stick, or torus fracture. From the age of the 11 to 15 years old, usually present with the type 2 injury. Most of the fracture heal will without sling or sweat for this patient. Close reduction attempt or operative treatment depend upon the age of the patient and degree of the strangulation and the amount of the displacement of that fracture. What about the shaft? Shaft is very important to divide to proximal, distal, and diaphyseal injury. Direct blow to that area can be torsional force from that fall or severe twisted, maybe result of the spiral diaphyseal fracture can happen for this patient. A mid-shaft fracture heal will even with the angulation up to 15 to 20 degree, or there is separation or overriding 2 centimeter. Use the sling and sweat for this one to young children, and maybe you can use the sugar tongue splint. Dr. Saleh, he will speak about the technique of what's the meaning of the sugar tongue splint or cast for adolescent. Fracture involving the junction of the middle and distal third of that humerus may be associated with the injury of the radial nerve. So think about the injury of the nerve of his lower third of that humerus. It's very important when you make good assessment for elbow about the fat pad for elbow if there is any fusion. Normal a true lateral view for that elbow fixed at the right angle. You can keep at the right angle. You can see that fat pad, anterior fat pad is accepted, but if he abnormal would be giving that window blown, that seal sign large. This one absolutely, this one can be labeled as abnormal, or you can find posterior fat pad is also abnormal for that patient. So flat anterior fat pad is often present with the normal children, and bulging or anterior fat pad or seal sign is always abnormal. So visible posterior fat pad is always abnormal for any patient. Also, there is other technique for detecting of that if there is any fracture or displacement or this supracondylar fracture. You can use the anterior humeral line. Anterior humeral line, you can measure or draw the imaginary line for this anterior side, anterior part of that humerus. That will be an intersect of the middle third of the capitulum distally for this one. If he's intersect this third and capitulum will be distally, will be this normal. If he not happen or cannot be the intersect of this third, that's when you think about displacement or there is fracture, supracondylar fracture. Other approach for this one, also the radio, or can use the that one. You can take the radial nerve or radiocapitular line. This radiocapitular line, any position or any angulation of that elbow, you can make that midline between the radius, and you can draw that line. You have to be bisect that capitulum regardless of that degree of the flexion or extension present. Failure for that one is maybe occult radial neck fracture or radial head dislocation. Supracondylar fracture is around 50 to 60 of elbow fracture. Usually common age from 3 to 10 years old. Present with the mechanism of Foch presentation, or 95% of this person present with Foch presentation, full on outstretched hand. Classification usually in 3 types: non-displaced, minimal displaced only, and type 2 is displaced but hinged or posterior cortex is still attached to each other bone. Third one is complete displaced or separated, that's the proximal from distal part of the fracture bone. Be aware about that compression of the medial column. So you can see this one. You can see the posterior fat pad for this patient. There is also increase the fat pad of that anterior, and you can see that fracture is very clear. That's type 1. Usually for type 1, no need, just only back slap and you can send home. Type 2, you can see this is separated but still hinge and attached from the posterior. This one, type 2, but the third one is completely separated from each other. So supracondylar type 1, a fracture can be managed with the casting. But type 2 and 3 usually fracture require operative reduction and internal fixation. Most children with the type 2 and 3 need to be admitted for 24 hours and 48 hours to be observed for neurovascular status for this one, or maybe reassess frequently for neurovascularity for that limb. Or maybe that patient need over reduction or internal fixation may be necessary in some cases. We are worried about that complication can happen by supracondylar fracture that can happen in the acute phase, that neurological injury around 8 to 15%. Sometimes maybe injury for anterior osseous branch or median nerve. Radial and ulnar nerve also maybe is involved. Radial artery is not common, but can be happen in 2% of overall. 50% of that radial nerve artery injury, usually in the type 3, can make radial artery compromise or injury for this one. Also, the compartment syndrome, one of the important complications can happen in the like this fracture. Long-term cubitus varus or Volkmann's ischemic contraction, that can one of that complication. Volkmann, this is ischemic, and that contour of that bone will be lost because ischemic and change of that contour of this one. That's capital for this one. For the capitis varus, you can see the capitis varus. This capitis valgus outside. This is the normal. But capitis varus will be inward inside of the body for this one. So maybe this in the long term if you not manage in the proper way. Lateral condylar fracture is around 15% of the elbow fracture, usually Salter-Harris 4. The big age from 4 to 10 years old. What the mechanism of presentation is the Bosch presentation for this patient, usually associated with acute neurovascular injury. Not usually associated with a neurovascular injury, but require aggressive intervention to prevent later complication can happen for that's non-anion or not junction or not classified in the proper way, or lose of the elbow mobility and growth rest in the lateral condylar phase. Sometimes can be present with the ulnar palsy. Management is usually operative. You can see that condyle is separated. Okay, lateral condylar area, and you can see also the lateral view. Medial epicondylar fracture usually seen in the adolescent boy, but can be involved the joint surface. You can check for that ulnar nerve injury in some cases. 50% associated with dislocation. Treatment usually non-operative, while is severe displacement or ulnar nerve dysfunction need consider relative indication for the operative management for this patient. Nearest mid elbow, one of that common presentation to the ER can occur between that age of 1 to 5 years old. This patient is precipitated by the traction of that arm when the patient is swinging by wrist and pulling by the arm or struggling in the quad can be find the interruption of that annular ligament between that head and the capitulum. So that patient will be keep in one position and he's in pain, but you cannot see any swelling, no any history of trauma. So we think about bolt elbow easy to be managed just by two technique, hyperpronation or supination. Just give analgesia before you doing that procedure. You will take few seconds, but very painful. So we have to be explain that procedure for the mother and explain what's happened for the child. After that, the patient will be move completely and go back to be normal. Diagnostic study, no need to if diagnosis is secure. So if you are sure about your diagnosis is not a nursemaid, so need classic history and no focal tenderness or bruising or edema. No need for an X-ray for this patient. Forearm fracture, it's very important to be more familiar for radius and ulna are the second most frequent injury born during the childhood, around 50% of all the fracture. The three quarter of all injury is involved the distal third of that forearm. Which one you have to be leave alone? Which one is be need to be reduction? Which one is need to consult orthopedic? It's very important. Most common in the age between the 8 to 12 years old, usually involve the metaphysis and faces and not to radial head. Salter-Harris type 1 and type 2 is of the radial neck is fracture are most common, but Salter-Harris type 3, 4, sorry, radial of the radial head fracture may be encountered in older children for this one. Any abnormal fat pad sign of abnormal radiocapitular line, you think about this is radial head fracture. Cranial fracture occur commonly in the combination with the other elbow injury. What management? Less than 15-degree angulation posterior back slab and follow up with the ortho. 15 to 13-degree angulation, you can keep posterior slab, back slab and easy early to be seen by the ortho. More than 30 angulation, no, you can call the ortho and for reduction. You can see this one. What you can find this one. Montegia fracture is very important. Montegia fracture is ulnar fracture plus proximal radio dislocation, proximal radio ulnar dislocation for this patient. Plastic deformation of that ulna occur in the 17% of that presentation. H17% associated with the neurological deficits, usually posterior interosseous branch of the radial nerve. Management called the orthoform fracture. Mid-shaft radioulnar injury reduction, any radioulnar angulation, any for any patient need to be for reduction, any radioulnar angulation or any rotational deformity or patient infant more than 25-degree angulation or children more than 10-degree for this one or pre-pubertal fracture can be. You have to be more make good reduction because that take time for remodeling and for healing more than 2 to 3 years for improvement. So it's better to be make good reduction for this one. Acceptable displacement if young as much as 90 degree for this patient. About bone deformity, patient present with this is will not be remodeled and very difficult. Must be reduced if visible deformity or restricted of range of the motion. But it's one of the difficult fracture you can deal with this one, the bone. It is if you are attempting to make with the reduction, check for the full supination and pronation to be sure is functioning well, and need early orthopedic follow-up with good consultation. Physical injury of that radius, usually the Salter-Harris type 1 and 2, usually displaced posterior. If we displace posterior, this is Colles fracture. If we displace anterior, this is Smith. Smith is common in the adults, not common in the pediatric. Which one need reduction for physical injury of the radius? Usually normal, you have to keep between 0 to 11 for tilt and distal at the distal radius splint. Want to be angulated at least natural and minimal displacement. Need to be good modeling for this, about 11% or will be need a slab for this patient. Cold ortho, unable to correct that dorsal angulation or more than 10 degree of displaced. Galeazzi fracture is radial fracture with plus the distal and the radioulnar dislocation. It's rare in the kid, but always can call for orthopedic. You can see that's fracture, distal fracture of that radius. Metaphyseal injury of the radius can be as a buccal fracture or grain stick or complete fracture. This one, buccal fracture, only one side and the other side is intact. This is grain stick. You can see angulation in the one side, the other one is there is fracture and separation. And this is one complete separation, this one. So buccal fracture is cortex in opposite side must be unaffected and there is a stable fracture. You have to be more familiar for this one and you can differentiate it from the grain stick. Grain stick usually fracture cortex is there is a fracture on one side and bent on the other side. They are unstable. They may tend to be moved to be back to position and of maximum deformity and maybe can change from grain stick to be complete fracture. Distal forearm for this patient, the most common orthopedic injury in the children from 6 to 12 years old of age. You can present with a history of mechanism of the fosh, tenderness of that physical and with the normal radiographic suggest of non-displaced Salter-Harris type 1 injury. You can splint the patient if you cannot see any fracture. If he is still patient, he is in pain. About torus or buccal fracture management can be treated in the removable splint and 4 to 3 weeks. If there is any complication, usually no complication. If there is no complication, you can be followed with the family medicine. If you have any complication, you can be consult orthopedic. Distal forearm grain stick and complete fracture reduction need for this patient if there is radial and ulnar angulation or there is rotational deformity or there is a patient, the infant more than 30 degree of angulation or children more than 15 or any angulation in the prepubertal age because take time for remodeling. Scaphoid fracture, one of that presentation of that upper limb fracture. are most commonly encountered for that carpal bone fracture, usually also in the present with the FOSH presentation. Usually the physical examination, we has a limitation of range of the motion from pain to swelling and tenderness in the anatomical snap box. You can apply short arm thumb spica splint, and you can refer the patient to early orthopedic for evaluation. What about metacarpal bone fracture? Metacarpal bone fracture, the neck, the most area for that fracture. Most metacarpal fracture and undisplaced or minimally displaced can be treated initially by splint immobilization. Displaced fracture can be generally be treated with the close reduction and splitting. Other type of fracture of the metacarpal, the boxer fracture, that fracture in the fifth metacarpal bone. You can see the fifth metacarpal bone. You can see this one fracture. You can see this fracture. Striking someone with the solid object with the closed fist hand, you can make displaced for this one. You have to make a close reduction for this one if is more than 30 degree or to 40 degree for angulation of that distal part of the fifth metacarpal bone. And with after the reduction, you can apply ulnar gutter splint with the orthopedic referral. Rolando fracture. Rolando fracture is one of that common fracture can happen with the thumb or the first metacarpal bone. So it's very common. He's communicated intra-articular fracture. We can in the base of the first metacarpal bone. And that fracture is consists of three distinct fragments, or you can give that shape of Y shape or T shape. Roland fracture less common than the Bennett fracture, but associated with the worst prognosis for this patient. Mechanism: this axial force applying on the thumb in the flexion position or blow on the fisted hand. Swelling and tenderness at the base of the thumb will be limited range of the motion of the thumb. You can see this shape on the like Y shape or T shape. Need for this patient pain control, immobilize, thumb spica. Majority require operative management. But Bennett fracture is different for that Roland fracture. Roland fracture is, sorry, Bennett fracture is also in the base of the first metacarpal bone, which is be extend and in the carpometacarpal joint. In the intra-articular fracture is that's most commonly type of fracture of the thumb, and is early always to be accompanied by some degree of subluxation or frank dislocation of the carpometacarpal joint. Okay, but the prognosis is better than a Roland fracture. Scarce injury or gamekeeper's injury is not fracture, is tearing of the ligament for this one, is tear of the ulnar collateral ligament of the thumb. This is injury can be happen when that your thumb is pulled back on the, to one side, okay, away from your finger. It often happen with the when the scare falls on that outstretched stretched hand that will be holding the scare bone, that will be make tearing of that ulnar collateral ligament. Then that like this one, you have to consult orthopedic and for repair of that part of that cutting ligament. middle and the proximal phalanx. This is the fracture are usually in the Salter-Harris type 2 fracture. Common fracture of the little finger proximal usually result of the extra octave finger, which will be under displacement of the little finger, need to be reduced and by fixation of the metacarpal phalanx joint and adduction of the finger. Also, that's important. Distal phalanx of fracture, mallet injuries are caused by effulsion of the extensor tendon. That's extensor surface, extensor tendon. This is the extensor tendon. That's one from the distal phalanx, or from the fracture of the dorsal base of the distal phalanx. An extension lag with this patient with this present with the mallet injury at the distal interphalanx joint is present, so that patient is unable to be actively extend the distal interphalanx joint. So in children with the present with the Salter-Harris type 1 or 2 fracture. The adolescents usually present with the Salter-Harris type 3 fracture. Need close reduction and splinting and slight hyperextension for this one. Yeah, just keep this one in this side. Hyperextension for this one and splinted for this one after fixation of this one. Almost done for that upper limb. Now we'll go the next topic for me. We will talk about lower limb. Also, the lower limb, one of that's important, you have to be familiar for this one in the pediatric emergency. So, fracture of that pelvis are quite rare in children. It's a part of multi-system trauma, usually present with the motor vehicle accident or significant falls. Patient present with usually with the pelvic fracture or ring fracture, stable or unstable for this one. Maybe the patient pelvic ring for this one. One of part of that important approach and examination in the ATLS to examine the pelvis if that pelvis ring is stable or unstable for this one. Acetabular fracture are rare in children, but almost all this associated with the hip dislocation. You have to go for AP X-ray for that pelvis. Are part of the most trauma protocol approach for any patient present to the ER. Usually good outcome with the conservative non-surgical management for that patient. The most important to be more familiar for a effulsion fracture that can happen for that hip. Usually the patient present to the ER, especially the adolescent with a strong muscle and hip apophysis for this patient is axial tuberosity. One of that can common part of that can happen for effulsion. Then anterior inferior iliac spine effulsion and anterior superior iliac spine, then the pubic symphysis, and the last one iliac crest. Initially, you have to just rest, then progressive range of motion, you have to be restricted. Then you have to do later on strengthening of exercise for the patient with rehabilitation for this patient. and give for painful non-onion patient or displacement more than 3 centimeters require surgery and to be seen with the orthopedic. This one explain most of that fulging can happen for this one. What type muscle will be make fulging this one? Lesser trochanter by the iliopsoas muscle, also the superior iliac spine, iliac spine. This one anterior iliac, superior iliac spine by serratus. Anterior or anterior inferior iliac spine by rectus femoris, and also the iliac is by the abdominal muscle. Also, that's greater trochanter by gluteal muscle, superposed by the abductor group, and escapability by hamstring. So hip dislocation is rare in the pediatric, but it's around 5% of all dislocation in this age group. Can present by the fault or sport injury due to that shallow acetabulum and increase the joint laxity for this patient, so it's easy to dislocate the hip. Severe discomfort or shortening leg and flexed hip or internal rotation for this patient. Patient may be present usually with the posterior dislocation without accompanied by fracture, or should be reduced within 6 hours by flexion of the hip in the 90-degree and providing axial traction to the thigh, maybe can be succeed to be make good reduction for posterior dislocation. Leg cuff birth disease is having 1 in every 3,000 children. A boy more common the girl. The big age from 4 to 9 years old, familiar in the around 20% of the cases. Is a vascular necrosis for the femoral head with trabecular collapse, secondary growth disruption, and deformity for this patient. If patient present with a symptom like pain in the area of the hip, need to refer to the knee. And this patient present with a knee area, hip tenderness, and we can he has some pain referred to the knee. So if your patient present with the knee pain, you have to examine also the hip to rule out any pathological problem in the hip. What the sign? A child, he can walk with the limping, decrease hip range of motion, need to go for imaging and order AB and frog like view for the hip. You can see the contour of that the femur. You can see how it's collapsed, and he lost of the smooth surface for this one. It can be sometime also this one also there is, but more severe in the left one, but can be present bilateral for this one. Also this one bilateral, but this more severe than compared to the right one. So late disease is early see within widening of that articular cartilage, appear as a joint space is widened. You can see widening for the joint space. Small dense epiphysis and get irregularity or flattening of that time of the contour of the head of the femur. You can see in this image. You can see that he lost the contour and this one and irregularity, and he is also there is widening of the joint. Yeah, we have to refer the patient if there is any difficult management for this patient, and you have the bracing or casting for about 1 to 2 years. Sometimes we may need to go for surgery, will be allowed the child back to be activity in the 4 to 6 months for this patient. Complication, Severe degenerative hip disease can happen for this patient in some cases and require hip replacement by middle age, around in 50 cases of back disease. Other presentation that's slipped capital femoral epiphysis is scurvy. This epidemiology can be incident in every 100,000. There is 4 cases. Adolescent is the common age during the growth spurt. Black more common than Caucasian people. Obesity is the risk factor for this presentation. Also, the tall and cylinder as a risk factor for that patient. The femoral head is smooth or slipped with the respect of the rest of the femur. The head of the femur stay in the cup of the hip joint, but the rest of the femur is shifted. So occur before the growth plate close. During this maximum growth spurt, usually in the male, usually the spurt growth or puberty around 13 to 15 years old, and female from 11 years to 13 years old. What's the classification of that and duration? Just can present as acute, acute and chronic, or chronic presentation. Stability of this patient usually some cases can be stable, able to walk in 90% of that patient, unstable or unable to walk 10% of that patient. Stable patient, you can usually history of intermittent limb and pain with several weeks or months and duration. Often poorly localized to the thigh, the groin, or the knee. So this patient, he referred the pain to the knee or groin area or sometimes in the thigh. So any patient present with the knee pain or groin area, or that you part of that examination, you have to think about patient with limping, think about maybe he has some pathological problem in the hip, so we have to think about hip X-ray and make a good assessment for the hip. Hip pain is reported less frequently. The fake history of patient present and you cannot call any attention to that limbic to that pain. Sometimes maybe challenging us, and you cannot easy to diagnose this patient. As the epiphysis continue to be slip, the child maybe lose the hip motion and including internal rotation and flexion of and abduction. Unstable patient present with the extreme pain, often after sport-related trauma or with the twisting injury. Most children have no prior history of or symptoms. Much higher rate of that avascular necrosis related to that disruption of the epiphyseal vascularity. What's the percentage? Hip healed in abduction and external rotation, limited internal rotation. What radiological finding and in the AB and frog-like position, you can see that's widening epiphyseal plate and displacement of the femoral head. One of the important for SCIFI to diagnose, that's a clean line. You can make the clean line in the base of the greater trochanter. For this one, you can make this line going with the upper border of the femur neck. And if we dissect 10% of that head, usually is normal. But if the clean line is just to not dissect or insect of that 10% of that head of the femur, that's think about that's slipped and SCIFI. See this one? Clean line, you just make part of that the head, but it's not approaching that 10% of that of that head of the femur. Also, this one and intersect any part of that femur. Also, when you draw also the line here, you can see a clear line here, clear, and also this one also. So sometimes can be bilateral. You can see difficult to weight bearing for this patient. Stable, you can strict non-weight bearing, refer to the orthopedic surgeon next to 1 to 2 days from the presentation. Unstable, strict non-weight bearing, and admit for orthopedic. Proximal femur fracture is less than 1% of that fracture around that hip. Complication, premature physial closure of vascular necrosis. Vascular necrosis can happen because it can cut or affect the blood supply for that area. Orthopedic consultation usually can be present with the effulgent fracture of that greater and lesser trochanter for this patient. Femoral shaft fracture, middle third of that femoral head shaft. This is that presentation. You have to make assessment for neurovascular status for and also pain control and splinting before that radiograph evaluation. Radiograph should be include that femoral shaft hip with the knee and hip to look for possible of dislocation or accompanied by injury, other injury. Orthopedic should be involved in hip with maybe going with the hip spike cast, or maybe can go for surgery for the majority of this case injury for this patient. Fracture of the knee or near to the knee or distal part of that femur, commonly injured in the sport and fall or motor vehicle accident. Very high risk in the growth arrest because it can be very close to the epiphyseal growth, or progression of deformity when either to be the region are involved. The distal femur septal hernia type 2 required reduction and occasional bending to ensure that anatomical alignment is achieved. The proximal tibial phases is rarely to be fractured because it is protected by the fibula and the insertion of the medial collateral ligament distal to the phases. So fracture of the patella when after one other presentation can be present, rare, but the large amount of the cartilaginous part or padding for this one, that's decrease the chance of that fracture. Examination of the knee, palpation of the bony prominence, phases and collateral ligament and distal pulse due to the risk of the injury near to that popliteal artery. You can go for AB and lateral X-ray and patella view to see the fracture, immobilization, non-weighting bear, and follow up with the orthopedic or sport medicine physician after 3 to 5 days. Osgood-Schlatter disease. Osgood-Schlatter disease is during the growth spurt, more boy in the antegrade, traction along that tibial tuberosity from that extensor mechanism. Common cause of knee pain with active adolescent usually sometimes can be bilateral up to 25% of patient. Management is just only supportive with ice or and non-steroidal anti-inflammatory drug. Usually self-limited condition that's fluctuated in the severity over the 1 to 2 years of period. Knee dislocation also is rare in the pediatric, but the high risk of popliteal artery damage in some cases around 40% with peroneal nerve or 33%, and for that's they had to go for consult the orthopedic for reduction and admission for frequent neurovascular checking for that's essential or the crucial point for that admission. Patella dislocation common in adolescents with sometimes going the lateral dislocation, and you have to go for reduction. This one happens spontaneously and just keep the knee in the extension prior to the examination, so it can be easy to reduct. Repeat radiological study for this patient maybe can be present with the osteochondrial fragment from that shearing force that's on the patella or femoral condyle during that dislocation, dislocation and reduction. Fracture along that shaft of that tibia and fibula, the most common long bone fracture of the lower extremities in pediatric, require high energy mechanism. Risk of that compartment syndrome can happen, and ischemia, especially in that fracture, is more proximal where the tibial artery is easily to be damaged. Tubular fracture is the occult tibial fracture, common in the young children with the limping and refuse to walk. Low energy mechanism, spiral in the presentation. You can see spiral fracture of the tibia, oblique radiograph, and impressive exam, and usually above the knee. You have to do a cast for 3 weeks and follow up with the orthopedic. Fracture of the ankle. The most common mechanism for fracture of the ankle is the inversion or supination of that, which places a great deal on the stress on the distal fibular faces. Most fracture of the distal fibular face is non-displaced. The distal tibia face is most commonly mentioned with the Salter-Hurst-2, but require reduction maybe accompanied by grain stick of the fibula. This Ottawa ankle rule you can apply in any patient present to the ER with the ankle or foot injury. If the pain in the malleolar zone or of ankle, if yes, any tenderness at the posterior edge of or tip of that medial malleolus or lateral, yes, or inability to bear his weight immediately after that injury, or he cannot step in the emergency 4 steps. If yes, ankle X-ray, and you have to do AB and lateral and mortis view for this patient. If the pain in the mid-foot zone, yes, you have to any tenderness at the base of the 5th metatarsal bone, or any tenderness or navicular or inability to bear his weight immediately after that injury, or cannot steps 4 steps in the emergency. If yes, foot for X-ray and AB and lateral view for this patient. So distal fibula, Salter-Hurst, usually Salter-Hurst type 1, clinical diagnostic, widening of that on X-ray, often not appreciated. If unsure, posterior slab or back slab, and follow up 1 week for reassessment. If fairly sure, below knee cast for 3 weeks, and walking cast is good option for this patient. What you can see this one, you can see that's fracture, okay, and this is telefracture. Telefracture is fracture of this anterolateral tibial epiphysis. That's commonly seen in the adolescents. You can see that's fulgent part of that distal part or epiphysis part of that tibia by the tibiofibular ligament. This one, a fracture of this anterior lateral tibial epiphysis that's commonly seen in the adolescents. That fragment is false due to the strong anterior-tibiofibular ligament and external rotation injury to the foot in relation to the leg. Low threshold for CT scan. If you are doubt, call ortho. Close reduction may be attempt. Will accepted maximum 2 millimeter displacement for that patient. What this one is, there is fracture, you can see here, and also there is fracture here, and there is separation for this one. So you can see 3 area of triplane fracture. You can see is involved also the epiphyseal growth, okay, and also the proximal and distal part for this one. So you can tell fracture plus Salter-Harris type 2 is equal Salter-Harris 4. The mechanism for external rotation of the foot and the leg basically is the pediatric fracture. The triplane fracture is occurring prior to the physial closure, usually from the age 12 to 15 years, male more than female. Usually significant growth plate damage, 50% of that fibula there is fracture with this one. Management, ortho evaluation, CT scan, usually close reduction in 30 to 50% of the possible OR for fixation, tender fixation. Foot fracture is very important. The majority of that fracture of the foot for foot fracture or metatarsal bone, this one an inversion of that ankle, direct blow or twisting force or fault. One of the other presentation is Jones fracture. Jones fracture is in the avulsion on the base of the 5th metatarsal, seen in the ankle inversion injury, rear the pediatric reduction when that's necessary, immobilization and posterior splint and non-weight bearing for this one. This frank is either to the ligament or broken bone in the midfoot area. You can metatarsal dislocation between the metatarsal and tarsal bone due to tearing the ligament, fracture with marked tenderness and swelling of the midfoot, oblique and weight bearing few to help for diagnosis of that presentation. Usually need surgical fixation for this patient. Foot fracture also there is calcaneus. Calcaneus rarely to be injured in children. Happen from that fall from significant height, and you can do that by AB and lateral or axial view. Also the talus fracture. Talus fracture is talar neck fracture, commonly site and fracture after force dorsiflexion. Usually anterior ankle pain, swelling, and that's inability to immobilate. There is posterior splint and non-weight bearing, and follow-up closely due to the risk of the osteonecrosis. Thank you. I think it's difficult and a lot of type of fracture. Sometimes you have to remember that's the common type of fracture can be seen in the pediatric. We have to be focused on this one. What's the good approach and what the good management for this patient? Dr. Saleh?
Just a few minutes. I'm going to start now, inshallah.
Any question for that fracture in the upper and lower limb? Some ask about what's the patellar syndrome. I don't know. Yeah, some ask about what's the ulnar gutter. The ulnar gutter, this type of modality of that splint. You just make that in the ulnar side. Just keep the splint or the cast around from the anterior and posterior to the ulnar side, and make the splint not in the back, just in the ulnar side, from the anterior and forearm or dorsal and frontal or volar side. I think it's better if you can explain by Dr. Saleh in the cast presentation. What's the first? This one, it is the first fall on outstretched hand. Fall in outstretched hand. That's mainly go for sure.
Yes, you're right, Dr. Hamid. Ulnar cutter is mainly used for 4th and 5th metacarpal bone fractures to fix it. It's sometimes doing back slab, extended back slab, if there is no expert people to do the ulnar cutter. But ulnar cutter usually mainly for the 4th and 5th metacarpal bone fracture.
Usually for that, but in the, I think it's good for patient if he has fracture in the little finger, you can splint it this one as like other finger, like you can just strapping of that finger, or you can deal with this one. But if he's, as I mentioned, is metacarpal bone, no need to be make a good splint this one by ulnar cutter for this one.
Any other question? Someone was asking here about the certificate at the end of the course. Yes, you will notice that these CME hours will be on your account in Momaris. They will start doing it from today and tomorrow. So just check, and within a week, if you didn't receive it, please contact our coordinator. The number is written, okay? تفضلي يا أمال.
And Dr. Saleh, he will soon to be presented as cast, but he has some technical issue for slides. He has some problem for retrieving that some video from the iCloud. He will fix it, inshallah, soon.
أهلا يا دكتورة عليا. Welcome from Oman. And guys, since we'll wait for Dr. Saleh till he prepare his slides and this technical issue will be solved. If you have any comments, if you have anything, if there is any topics that you wish that we can add it next time, please let us know. Okay, I think my all of us, our contact and everything, you have it. Okay. Anonymous, I have an interesting question for this anonymous attendee. Who are you? ليش كاتب اسمك anonymous attendee؟ يعني you are ما شاء الله almost 70% of the question coming from you. Either you should tell us who are you, or we will not give you the certificate and the CMA hours. دكتور صالح ready؟
يلا بسم الله الرحمن الرحيم.
بالتوفيق.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. طبعا just before I'm going to start the presentation was containing much more picture than this one, but you know, because of my update in the iCloud for OneDrive, and my advice صراحة لا تستخدم البرزنتيشن تفتح من كذا جهاز. Don't open your presentation work from many devices. Just limit it for 1 or 2 devices. If it's any editing or any canceling slide from any of those devices or even from mobile, it will go through all and you cannot return it back. So that's what happened to me. وأنا صراحة I tried to retrieve all the slides since 3 a.m. to make it all. لكن that's what I could retrieve it from my previous presentation. نقول بسم الله الرحمن الرحيم. I'm ready for any question إن شاء الله later on. What's a POP cast? Is the aim of the plaster is to immobilize الcast. الهدف منه طبعا is to immobilize part of the bone and to prevent the worsening condition and to make helping growth and rehealing of the bone and minimizing the pain. The plaster cast or fiberglass is a rigid immobilized device that is molded to a contour of the body to encase the injured part. البوب هذه من الاسم اللي هو Paris plaster of Paris means plaster of the Paris, which is hemihydrated calcium sulfate. When you add water, it will be solidified and molded quickly. ميزته طبعا انه dry quickly, is not staying wet like الجبسونة that we know it from outside, take longer like 2, 3, 4 hours until it be dry. This one it will be dry within seconds, and this is the old almost now we use it for more than 50 years using this cast. Purpose of the cast and or slab is applied as a first treatment to immobilize the bone or joint. It acts as a splint to apply pressure on the bone and to correct further complication. Also to observe sign and symptoms after applications. Minimum within 1 week need to be follow up after the making the cast. The cast here is to immobilize the body part in specific position, is to apply uniform pressure on the bone to provide support stability for 4 weeks joint and to prevent micro movement. This micro movement, it can prevent healing of the bone. So the cast will prevent the micro movement and joint and the bone fracture. What's the indication for cast here? Bone fracture is not only for fracture, but also for dislocation, for soft tissue injury, to prevent the movement or excessive movement, ligament injury also ligament post-operative, joint swelling due to some diseases like septic arthritis, when you want the joint not moved or slow movement. Also when there's nerve, tendon, and physical repair. Actually, it's also calcaneus tendon, if the tear or rupture or inflamed also. What type of the cast? We have many cast types, but we'll speak about the commonest here. We have long arm cast, which is above the elbow. It's applied to the arm from the hand to about lower 2/3 of the arm, leaving finger and thumb free. This will not affect the fracture, and the indication for elbow and forearm injury. Also for distal humerus fracture. If both bone of the forearm fracture, unstable proximal radius or ulnar fracture. And here, and by the way, my sources of the video is from open sources, and they ask for a fee. I already paid for them this way, but I'm trying to cover the face here.
This right here. Okay, thank you. Now we're gonna just roll it down.
This is for back slap above
Make
elbow.
sure that it goes all the way up, because when you put the cast, every time it comes down a bit. So try to make it all the way up to the shoulder. Once you got that done, we're gonna put now this protective cotton, make another hole for the thumb. There you go. Make sure to get nice protection of all the bone eminences. And if the children has a wound from an exposed fracture or something, make sure you get a really nice padding of that area, so you won't have any problems with the soft parts. The elbow, go all the way up to the near the armpit. Okay. Now, before you put the cast, make sure your position is right. The cast always leave about 10 centimeters unwind, so you can put it in the water and then you won't have any trouble getting it out. So we're gonna put it here. Make sure no bubbles are coming out of the cast. Let the water drain by itself. Do not squeeze it, because then you will lose the materials. And now we're gonna start up here, 2 whole turns. Make sure to have the right tension, not too tight, not too loose. And now we cross over to the forearm, protecting the soft structures that cross on the other side of the elbow, and go back up. We protect this, and now we cover it. Make sure the cast rolls over itself. Do not lift it like that. Just make it roll. This is our first cast. The second one, same thing. Unroll it about 10 centimeters.
So remember, this is not back
Get it
slap.
wet
This is
till no
full
bubbles are
cast
coming out.
to prevent any movement
Let it
of
drain.
the forearm.
And since we already did the elbow, we're just gonna go straight down to the wrist and back. Okay. This right here. Let it drain. And since we already did the elbow, we're just gonna go straight down to the wrist and back. Okay. Some people make a cut here to go through the thumb. Some people just do this, no cuts. Make sure you go around the wrist almost 2 or 3 times.
Is the sound clear? The video? Right. We'll go now to another case about short arm cast. Cast, which is below the elbow. What's the indication for short arm cast? It's distal forearm fractures, carpal and wrist injuries, and some metacarpal fracture, pediatric buccal and minimal displaced distal radius fracture, minimal displaced fracture of the distal radius in adult, immobilized of the forearm after surgery. The good things with this one, he feel more free and he can move the elbow, and less, he's having more comfortable with this type of short arm cast.
Net, 1 3-inch soft roll and 2 3-inch plaster rolls. Measure an appropriate length of stockinette to ensure full coverage of the forearm. Cut a thumb hole at an appropriate point in the longer piece of stockinette. Measure a second short length of stockinette to cover the thumb. Split this stockinette along one crease over half its length. Roll the stockinette onto the arm up to the elbow crease, avoiding bunching which could irritate the underlying skin after the plaster is applied. Cover the thumb with the short length of stockinette, orienting the split end toward the first web space. Begin wrapping soft roll proximal to distal, starting approximately 2 finger widths distal to the elbow crease. Wrap 2 layers of soft roll proximally and then proceed distally, overlapping by about 50%. Tension the soft roll throughout the wrap to avoid bunching. Wrap in a crisscross fashion around the hand and wrist, tearing soft roll while passing through the first web space. Finish with 2 layers of soft roll on the hand, extending no further than the palmar crease to leave the metacarpophalangeal joints free. Wet the first plaster roll and apply from proximal to distal, starting with 2 layers and proceeding distally, overlapping by approximately 1/3. Tension the plaster appropriately to keep snug. Wrap in a crisscross fashion around the hand and wrist, pinching the plaster while passing through the first web space. Fold over stockinette proximally at the base of the thumb and distally. Wet the second plaster roll and apply in a similar manner as the first, ensuring that there is no contact between the finished cast and skin. Mold the cast appropriately as dictated by the fracture pattern. While still wet, smooth the plaster to provide an even finish. The finished cast should allow excellent movement at the metacarpophalangeal joints, base of the thumb, and the elbow. Net, 1 3-inch saw.
There is another thing called arm cylinder cast. Arm cylinder cast, which is cover the upper and lower arm and elbow, but leave the wrist and hand. It's like cylinder. It's indicating for elbow dislocate, but having some contraindication that most acute fracture can be used, open fracture, injuries with the neurovascular compromise, fractures with active swelling. Here we'll speak about, I thought there's a movie about this one. I think already I lost it here. Finger or thumb spica, I think this is many emergency, they like to use it, especially with suspected injury in the hand and the wrist. It can including long arm cast and short arm cast covering the thumb or finger. The indication here is suspected injury to the scaphoid, stable ligamentous injury to the thumb, initial treatment of non-angulated, non-displaced, and extra-articular fracture of the base of the first metacarpal. هذا حيكون عكس اللي هو الألنر gutter splint.
Required supplies include stockinette, 1 3-inch soft roll, 1 3-inch plaster slab, and 1 2-inch roll of flannel. Measure an appropriate length of stockinette to ensure full coverage of the forearm and hand. Cut a thumb hole at an appropriate point in the stockinette. Cut a second short length of stockinette to cover the thumb. Split the stockinette along one crease over half its length. Roll the stockinette onto the arm up to the elbow crease, avoiding bunching which could irritate the underlying skin after the plaster is applied. Cover the thumb with a short length of stockinette, orienting the split end toward the first web space. The plaster slab should be approximately 1 inch shorter than the distance from the elbow crease to the tip of the extended thumb. Trim the slab as needed. Trim one corner of the plaster slab using a lazy S cut. Begin wrapping soft roll proximal to distal, starting approximately 2 finger widths distal to the elbow crease. Wrap 2 layers of soft roll proximally and then proceed distally, overlapping by about 50%. Tension the soft roll throughout the wrap to avoid bunching. Wrap in a crisscross fashion around the thumb, hand, and wrist, tearing soft roll while passing through the first web space. Ensure that there are 2 layers of soft roll on the hand, extending no further than the palmar crease to leave the metacarpophalangeal joints free. Tear off any excess material. Wet the plaster slab and apply it to the radial surface of the forearm and wrist. The trimmed corner should be centered on the interphalangeal joint of the extended thumb and wrapped around the base of the thumb on either side. Fold over any excess length proximally to ensure the plaster does not overhang the soft roll. Fold over stockinette proximally over the tip of the thumb and distally. Overwrap the plaster with flannel from proximal to distal, overlapping by approximately 50%. Tension the flannel appropriately to prevent bunching, but avoiding excessive compression of the forearm. Wrap in a figure of 8 manner around the thumb. Mold the plaster to set in the desired position as dictated by the injury. The finished splint should allow excellent movement at the metacarpophalangeal joints and the elbow while immobilizing the thumb. Required supplies include stockinette,
sugar tongue splint. Sugar tongue splint are used to stabilize injury of the forearm and wrist by preventing forearm rotation and wrist motion. The indication here, initial treatment of distal radius fracture, initial treatment also of isolated radius or ulnar fracture, initial treatment for fracture of the shaft of both the radius and ulnar, also post-operatively protective of the forearm or wrist.
This is a sugar tongue splint.
Okay, so we'll go now to the lower extremities. There is also short below knee and above knee cast. Below knee cast, it's including the encasing of the foot and ankle and lower leg ending below knee. It's actually much more comfortable than the cast above knee. Indication, lower leg fractures, ankle fracture, and severe ankle sprain and strain. It's used to hold the leg or foot muscle and tendons in place after surgery to allow for healing. Applied to the area below the knee down to the foot. Of course, will be calculated from the midshift of the lower foot to downward.
And now we're just gonna put this sock under here to protect their skin. So this sock goes all the way up a little bit past her knee and comes past her toes. Then we put a little crease in here to protect the skin of her ankle, which is very tender right here. So then we use this thing called a casting stand. And we slide her foot right over the top here and inside of that sock. And the point of the casting stand is to hold her foot at 90 degrees to her leg to make sure this Achilles tendon in the back is not too tight. But when she goes to rehab, she'll have a much easier time when she goes to rehab. So we're already thinking about her rehab and trying to make it easier. So once she's in this position, then we just apply cast padding to the area. Give her a nice padded cast here. Couple things, we want to make sure the heads of the metatarsals are really well padded, which are right up here in the front of the foot. We want to make sure her heel is really well padded.
Okay.
And now we're just gonna put this sock under here to protect their skin.
So about lower extremities, that long leg cast, it's above knee cast. It is for all proximal tibial and tibial fractures and the mid shaft of the femur fracture. Also mid shaft of tibia and fibula. Sometimes use it. The above knee cast. It's mainly for non-displaced supracondylar fractures of the femur and should be stable fracture. One more things about bivalve cast. Bivalve cast, this one, it's a cast being cutting into two half. It's being used for frequently inspection of the heel. So just put the cast to stabilize the bone issue there, and they can open it in the clinic and see frequently any infection or any swelling or any deformity of the leg or the arm. Bivalve, it use both for arm and also for lower leg.
The secret to this is that you get his heel all the way down in the heel cup, like that. The heel has to go all the way in. That will be a stretch.
Yeah.
And that's okay. Look at it, you got the needle on the shot. And then you put the top on. And you want the sides to completely close. The straps will help you with that. You take the top strap, pull it around, Velcros to itself. You take the bottom strap, that's a little trickier one, and you wrap it around the back, around the front to make like a figure 8 so that it does a crisscross on the front of his ankle to hold him down. This one is taped down. You never have to undo that one. That's just to make it long enough. And you pull tight. If they don't close all the way, then all you need to do is just give it a couple minutes, then go back in a couple minutes when he's a little relaxed and give him another pull to tighten it up a little bit more. Like this one, give that on a couple minutes. I could probably give that an extra little tug and get it closed completely. They're labeled left and right, and the backs have an R and an L on them. They would cause a skin issue if you didn't put them on the right feet.
Finally, I believe this is the last slide, but hopefully, inshallah, when I bring back all my slides, inshallah, I will send it, inshallah, to all of you, inshallah. Thank you very much, and I believe I'm the last one. My last presentation. I would like to thanks everyone who attend and asking me. جزاكم الله خير جميعا. I'm ready to answer any question you need. طيب إذا نعلن إن شاء الله انتهاء الكورس تروما، وإن شاء الله بإذن الله نلتقي بكم جميعا إن شاء الله في كورس آخر أكثر تطورا بإذن الله. سنعمل بإذن الله جاهدين على تطوير موضوع الكورسات الأونلاين بشكل أفضل بحول الله عز وجل، ومع إن شاء الله مع المجموعة كاملة بإذن الله. توقع إن شاء الله بإذن الله سيكون فيه في اجتماعات قريبة بحول الله عز وجل. نسأل الله عز وجل التوفيق من عنده لنا ولكم جميعا بإذن الله. وآخر ما ننهي الكلام بالصلاة والسلام على رسول الله سيدنا محمد عليه الصلاة والتسليم. شكرا لكم، وسنقوم بإغلاق الآن الويبينار الآن بإذن الله.